Trusted, credible, nonpartisan. The Hill's unbiased news and analysis on policy and politics is delivered straight to the halls of Congress with unparalleled engagement in the Beltway and beyond. A new administration, a new Congress, and a new position on healthcare. From enterprise reporting to breaking news to live events, The Hill stays on the pulse of what's next in health. Welcome to The Hill's Health Next Summit.
Going to begin. Let me welcome the Senior Vice President of Editorial Content for The Hill, affectionately known as Super Stretch by George W. Bush, Bill Salmon.
I've been called worse. Thank you, Steve. Good morning, everybody. Good morning and welcome to the Hill's Health Next Summit. My name again is Bill Salmon. I'm the SVP of Editorial Content at The Hill. We're so delighted that you're here today. You know, The Hill does more healthcare events than anyone else in Washington. This is actually one of two kind of amazing facts I want to share with you today. We do more of these than anybody, so we knew coming into 2025 that healthcare would continue to be a major issue, both politically and policy-wise. In fact, that's why we created the Health Next Summit. So we're very excited to have you here, and that's why today we're going to be talking we're going to be hearing from fantastic doctors, lawmakers, patient advocates. We're going to explore some of the healthcare-related campaign issues that were made by the Trump team, and we're really going to dig into some of the issues at the top of the healthcare agenda. You know, I'm talking about women's health, mental health, AI, emerging tech, you name it, we're going to cover it. And in fact, we got so much to talk about that we're going to do this all over again on October 22nd. That's when we're going to do the next edition of the Health Next Summit, so we hope you'll do that as well. I just want to say briefly how proud we are at the Hill of our nonpartisan coverage. You'll see some of that today firsthand. But I want to, one other kind of interesting fact, we grew our audience by 17% last month. And for context, and I had to triple check this to make sure I was giving you straight information, that is literally there's been no larger increase of any news organization, not only in the country, but on the planet. So we had a very good month. We're happy to grow our audience. We're happy to have you as part of our Hill family today and hopefully moving forward. We hope to see more of you. Again, I want to welcome everybody in this room. I want to welcome everybody who's watching on our live stream. If you're following along on social media, you can use the hashtag #TheHillHealth. Of course, I want to give a special shout out to our sponsors, the Alliance for Aging Research and the National Pharmaceutical Council. Their generous support has made this all possible. And now, without further ado, I want you to welcome, help me welcome to the stage one of your hosts for today, the Hill's contributing editor and my old pal, Steve Scully. Steve, take it away.
Just real quickly.
Okay. Obviously, when I started covering President Bush, I said to him, I had an interview with him. I said, what is this I hear about you calling one of the reporters in the White House press corps Stretch? Because there was another reporter, Dick Kyle from Bloomberg, who's 6'6", which I call short. I'm 6'7". And he said, well, I guess we'll just have to call you Super Stretch. So for literally the next 8 years, we'd be down in South America at a press conference, and the president would be like, Super Stretch,
Yeah.
So that's how I got the nickname.
A sign of affection and admiration.
Yes.
So,
like I said, I've been called worse.
Now you know the rest of the story. Thank you all. Pleased to be with you all. And as Bill indicated, in addition to working for The Hill, I have a show on Sirius XM, and I rely on The Hill every single day. It is a terrific site. Just some of the headlines today dealing with healthcare. You might have seen it. You may not have. There are 5 high-level officials at the CDC who have now stepped down. The CDC is one of the most trusted public health organizations and government agencies in the country. Here in Washington, D.C., another case of the measles, now joining 18 states with measles cases in this country. And Dr. Oz moving one step closer to becoming the Director of Medicare and Medicaid Services. So you can read all of it at thehill.com. Healthcare, of course, is not just an important issue. It's also something that took center stage at the Grammys just a short while ago. Look at the monitor.
The Grammy Award for Best New Artist goes to Chapel Rock!
I told myself if I ever won a Grammy and I got to stand up here in front of the most powerful people in music, I would demand that labels and the industry profiting millions of dollars off of artists would offer a livable wage and health care, especially to developing artists. And like most people, I had a difficult time finding a job in the pandemic and could not afford health insurance. And if my label would have prioritized artist health, I could have been provided care by a company I was giving everything to. So, record labels need to treat their artists as valuable employees with a livable wage and health insurance and protection. Labels, we got you, but do you got us?
Just an important reminder of the importance of this issue. So some terrific guests here today, including our first speaker, our first Q&A, Representative Diana DeGette. She is a ranking Democrat on a key House subcommittee that focuses on healthcare issues. Welcome. We appreciate you being with us. So welcome back, and let me just begin with the issue that is front and center, which is the Trump agenda, the big, beautiful bill that includes potentially, that's what he's calling it, but potentially could include some significant cuts to Medicaid, the debate over health care, Medicare, and Social Security. What are you expecting?
That's kind of an unfair question, Steve, to ask me. What am I expecting from the Trump administration? We were just opining about how every day there's some new interesting surprise from them.
Are you on Signal right now?
Right. I'm not on Signal with Secretary Herseth or some of the others. But seriously, thanks for having me back again. And I will tell you, it has been chaotic with the Trump administration. But the other chaos is created by the fact that the House Republicans have on any given day just a 1-to-3 vote majority. And so they're trying to do this very big agenda with the slimmest of margins and with an American public that disagrees with them on most issues. So as you referenced, in their budget resolution passed by the House, and virtually only one Democrat voted for it, and only one Republican voted against it. It said it's a $4.2 trillion budget, and the $4.2 trillion budget is going to be offset by $2 trillion from Congress. And then they said that the House Energy and Commerce Committee would have to cut $880 billion of that. Now, the House Energy and Commerce Committee has jurisdiction over about 40% of the bills that come through Congress, anything relating to the Commerce Clause of the Constitution. But most of the bulk of our budget in energy and commerce is in the committee that I'm now the ranking Democrat on, the Health Subcommittee. And most of that is Medicaid. In fact, coincidentally, the budget resolution told us to cut $880 billion from the Energy and Commerce Committee. The amount of Medicaid is $880 billion. So then we said, excuse us, but over 70% of Americans support Medicaid and don't want to see it cut. In fact, they want to see Medicaid expanded for more populations. So where are you going to get those cuts? The entire rest of the energy and commerce jurisdiction, and that includes the EPA, energy, telecommunications, all of those issues, is less than $500 billion. So any way you slice it, anything the Republicans might say, if they're going to cut $880 billion from my committee, it's going to have to be Medicaid.
So, tax cut issue aside, if you look at the federal budget, Medicare, Medicaid, the SNAP programs, Social Security, interest on the debt, defense, collectively that is about 85% of the federal budget. Can you make some cuts to the Medicaid program without to offset a now $37 trillion national debt?
So in truth, the real problem that we have with this $4.2 trillion budget that they have is that they want to extend the 2017 tax cuts that primarily go to the top 0.1% of taxpayers, billionaires, and corporations. So without, it's economics 101, which I did take that in college, and what that means is if you're going to have a tax cut that large, then you're going to have to offset it somewhere. Thank you very much. That's much better. It's really hard to keep repeating it because the sound system's not working. So if you don't have the revenue coming in, you could cut everything and still not offset that. I come from Colorado, and in Colorado, we have a constitutional amendment that says you can't deficit spend. And I was in the Colorado legislature. We didn't deficit spend. So you can do it without deficit spending, but you can only do it if you have revenue coming in. And that's the problem, is they want to cut the revenue that's coming in by these large tax cuts. There's not anywhere in the discretionary budget that would allow them to offset that.
But isn't the other part of the problem rising health care costs, and how do we bring those under control?
Well, there's a lot of things we could do to deal with rising health care costs. We could deal with pharmaceuticals. We could deal with a lot of things. But to do that, you can't just do what Elon Musk and Doge are trying to do with their 20-something-year-old kids, is just slice whole things off of the budget. Because when you do that, you harm real people. If you want to try to get some savings in the healthcare system, you have to do the hard bipartisan work of having the hearings, of figuring out where those excesses are, where you can save money, and then try to save money. And we've done that in the past on the Health Subcommittee and on Energy and Commerce. But and I think you should do that, but if you do that, there's no way you're going to save $4.2 trillion.
Do you have confidence in the Secretary of Health and Human Services, RFK Jr.?
So I have confidence in science. As many of your listeners know, I have worked hard over the years in a bipartisan way to make sure that we continue to be the top nation in the world on biomedical research. And all of this needs to be based in science. I worked with Congressman Fred Upton and Francis Collins and others on the 21st Century Cures Act. I'm now trying to work to update that and find a new Republican partner on that. And I believe the research we do at these preeminent research institutions, including the NIH, should be based on science. The issues I have with some of the positions that RFK Jr. believes in, they are not based in science. And I think that is a very dangerous road for our preeminent research institutions to be going down.
So, Congresswoman, when it comes to science, when it comes to research, when it comes to the federal investment in these research opportunities, what we're seeing at universities around the country, what worries you the most over the next 3.5 years?
What worries me the most, so the first time Donald Trump was president, there was a general feeling that there was and he had some people who were, like Dr. Collins, Collins and others who were running some of these institutions, who understood how biomedical research works and who understood what we need to do. Those people are gone now. And I think there's a real, number one, there's an ideological bent in some of the people now who are coming into leadership positions. And number two, there's a lack of understanding about what these institutions need to do. And I'll give you an example. A couple of weeks ago, cast your minds back, and a couple of weeks ago, the administration tried to zero out the 15% amount that was given to grant recipients for overhead. I got a call from Anschutz Medical Center at the University of Colorado, a huge recipient of NIH grants, and they were telling me when you zero out that 15%, what you're doing is you're zeroing out their ability to get lab rats to run studies, to get the blood supplies, to build the labs. But obviously someone over at Doge or somewhere said, oh, that's 15%, that looks like it's just gravy, I'll cut it. So my concern is the people who are doing this research need to make sure that they are doing it in a cost-effective but science-based way. And you know, I'll say this again, disease does not impact Democrats, Republicans, or even unaffiliated voters. It impacts every American family. And so we should be doing our biomedical research based on science, not on political ideology.
I don't want to overlook something that you said, and this really gets into the weeds of how Congress works, but you mentioned the 21st Century Cures Act, and you have worked in the past with people like Larry Bouchon and Michael Burgess, Republicans across the aisle. Is that not happening right now in this Congress from your standpoint?
Well, from my standpoint, I continue to try to work with everybody. So, for example, I know that you've got Chairman Carter, Buddy Carter, who's the new chair of the Health Subcommittee, on your agenda today. I've already met with him to talk about Cures 2.1, which I developed with Congressman Bouchon before he retired, but which is ready to go and with a new co-sponsor. So I've met with him to talk to him about that and other issues, important issues that the subcommittee has to work on. I've also met with the chairman of the full committee, Brett Guthrie, about agenda items, as well as Frank Pallone and others. So I'm agnostic about party affiliation if we're talking about biomedical research. The problem with this Congress is we've been spending most of our time dealing with the Trump agenda and dealing with this budget resolution. And so, for example, in my subcommittee, in the health subcommittee, we've only had 2 hearings so far, and we haven't had a markup. So I do believe there's a potential for bipartisanship, and I'm hoping my colleagues who come here later today will talk about that. But so far, because of the congressional calendar and the Republican priorities, I haven't seen that happening.
And with regard to the research, from your standpoint, where are we today? Biomedical, Alzheimer's, cancer, and the rest?
Well, we are, so much of what has happened in the last 10 years even has put us on the cutting edge of cures for so many diseases. One of the things I do, I'm the co-chair of the Diabetes Caucus along with Gus Bilirakis in Congress, and an issue that I worked on 25 years ago, the issue of stem cell research, has now come to the forefront because there are researchers out of Harvard who have actually been able to make insulin-producing islet cells with stem cells, and they're in clinical trials right now to do that. So and if that works, it will cure type 1 diabetes. Same thing with cancer, same thing with Alzheimer's and many, many other diseases. That's why we have to have evidence-based research, and we have to adequately fund it.
You know, ironically, today is the anniversary 7 decades ago of Dr. Jonas Salk, who really cured polio. Do you have confidence that this administration will do what needs to be done to continue the research to find the cures?
I think that's a question for you to ask my Republican colleagues. I will tell you, I intend to do everything I can, and I believe that I have colleagues, Republican colleagues, and also people in the research community who know what needs to be done and believe that they can cause those efforts to be made. But some of the people thought that the NIH budget was sacrosanct, and we saw efforts the first efforts were to cut the 15% grants and to cut other grants that somebody determined were DEI or something else. But then when the courts ordered the 15% overhead to be restored, then the administration started trying other backdoor ways to try to stop this research by not having the grant approval committees meet and other things. We're working through that, but that is those are delay tactics that we really shouldn't be having when you're looking at approval of research.
So let me conclude where we began talking about Medicaid. What is it, about 70 million Americans are on Medicaid today?
That sounds about right.
So are there ways that we can weed out the waste, the fraud, the abuse, and in some cases perhaps a work to get the benefits for those who would qualify? How do you get the equilibrium in that?
It's interesting because nobody likes waste, fraud, or abuse. I'm against it. I'm against waste, fraud, and abuse, you'll be happy to know. And I think we should continue to have hearings and try to figure out ways we can do it. I will say, cutting the staff that does the inspection and the rooting out of the waste, fraud, and abuse is probably not the way to solve that problem. But also, if your entire budget for Medicaid is $880 billion, you're not going to save $880 billion just by rooting out waste, fraud, and abuse. I've been now in Congress, I'm in my 15th term. I've been here 28 years, and every time the Republicans take over, they say they're going to balance the budget by eliminating waste, fraud, and abuse. Waste, fraud, and abuse is bad, but it's not the top problem in America. And what's interesting is since the Affordable Care Act passed, an increasing number of Americans have gotten their health care through Medicaid, either with the ACA, the Medicaid expansion after COVID. And so now, well over 76% of Americans say you should either keep or expand Medicaid because they know it's helping pay for their insurance. With respect to the work requirement, let me just say briefly, a number of states have tried this work requirement, but what they have learned is most people who are on Medicaid are either already working, or they are disabled, or they are elderly, or they are children. And so pretty much everybody who should be working is working, but what in those states what happened was the paperwork, I don't know, I'm all for paperwork reduction and efficiency, but the paperwork reduction or requirements for those beneficiaries were increased so much, many of them couldn't figure out the system, so you actually had people who were eligible, who were working, who were thrown off of Medicaid.
So if your party has a majority in 2027, is it Chairwoman Diana DeGette?
Well, maybe. That would be my hope, because I think, whether I'm in the majority or the minority, the most important thing to me is to protect health care, make it affordable for all Americans, and to make sure that we have the exciting biomedical research that's going to cure these diseases and save lives.
28 years, you're just getting started.
I know it. My constituents say, when are you retiring? And I say, I'm just getting powerful. Why would I quit now?
A powerful representative. Thank you very much for being with us.
In my own mind. Thank you so much.
We appreciate it. Thank you. Let me direct you to the monitor.
My colleagues are laughing, and I just want to be really clear again, as a pediatrician, we should not have to wait for kids to get sick and kids to die because you think this is some sort of joke. When there are experts representing public health in this country, who sow doubt about proven science, about vaccines, cause parents to hesitate, and some of them then to not vaccinate their children, and their children get sick, potentially die, or their children bring diseases to school, to the child in that classroom with leukemia. This is not a laughing matter.
Kim Pryor. She is a Democrat, a pediatrician, a member of the House Energy and Commerce Subcommittee, the newly formed caucus dealing with congressional doctors, in conversation with Julia Manchester, the terrific political reporter from The Hill.
Good morning, everyone.
Good morning, everyone. Good morning, Congresswoman. Thank you so much for joining us. I just have to say, I'm very passionate about women in elected office and women in STEM, so it's great to see two Congresswomen involved in, medicine, the STEM field, back to back. So welcome. Thank you so much for joining us. I guess on a slightly darker note, there's been some news in the D.C. area along the East Coast about measles outbreak and sort of measles arriving in the Washington, D.C. area. The U.S. has recorded more than 300 cases of measles in just the first 3 months of this year, according to CDC data. Congresswoman, as a pediatrician and a lawmaker, I'm going to ask you a pretty obvious question. Why is this alarming?
Oh my gosh. Well, first of all, thank you for having me here. Thank you for your interest in this topic. I did not intend to wear the exact same suit today that I was wearing there. And I just want to say that it was really a pleasure to sit backstage and see Diana DeGette, because she's one of my role models, and I've been in this for 6 years. Okay, so why is this concerning that 347, I believe, cases of measles just from the Texas outbreak? Here's the thing with measles. First of all, it is the most contagious disease in the United States of America. So if you are a person with measles and there are 10 people around you, 9 of them will get measles. If you have measles and you are in a room, maybe not a room this size, somebody could come into that room 2 hours later and breathe the air you breathed and get measles. So I just want to be really clear how infectious this is. I also then want to be clear that in the year 2000, measles was declared eradicated from the United States of America. Think about what an achievement that was, that we went from a disease that just about every child got early in life to nothing. So since then, right at about that time, the whole vaccine denial, vaccine skepticism movement came. Social media has only accelerated that. But it came about because of a quack science, a quack doctor, I'll say that, in England, who just spewed a theory that was subsequently proven false. But now parents have stopped vaccinating children in some cases. And when that happens, all of a sudden measles gets a foothold, as we've seen in Texas. And so it is incredibly concerning, because when vaccination rates drop, this thing could just keep going like wildfire across the country.
I want to stick with this topic because Health and Human Services Secretary Robert F. Kennedy Jr., he's off to a bit of a bumpy start when it comes to this issue. A lot of his critics point out that he has voiced vaccine skepticism, and he's gotten some backlash response to this outbreak. Wanted to get your take.
Well, I mean, bumpy start. Like, there shouldn't have even been a start. His vaccine skepticism should have been a disqualifier from this role of being in charge of our country's public health, when he does not believe that vaccines are useful and thinks they do more harm than good. I mean, that should have kept him from even getting the start. So I'm outraged, and children don't get to make the decision of whether to get vaccinated. Their parents are making these decisions for them. And when you take somebody and you give them that platform, you're putting these children, measles is not just a rash. Like, measles is miserable. I've seen exactly one patient with it in the year 2002 who was adopted from China, so came from a country with low immunization rates. It was too young to be immunized. That child was so miserable, with fevers in the 104-degree range, crying. I mean, this is not just like a little itchy rash. This is a bad disease, and it's making children miserable, putting them in the hospital, and causing them to die because of people like RFK Jr.
President Trump in February launched the Make America Healthy Again panel, commission, I should say, also with RFK Jr. What is your take on that panel? How are you looking at it?
I think that if you're going to put people on a panel about making America healthy again, you should put real scientists and people in public health who have been doing this for years and are devoted to it. You should not be putting people who are vaccine skeptics, et cetera. But I also want to say that I think we can all get behind the fundamentals of this. We have a big problem with chronic disease in our country. We have a big problem with the foods that we eat, the diets that we eat, how they are likely connected with what happens later in life. There of healthcare, I think that we can lend a really important, strong voice, and the doctors, Democrats and Republicans, we join together and share a lot of these concerns.
We chatted with Congressman Buddy Carter for this event too, and he was talking about how, he's still a licensed pharmacist. And I think a lot of people looking from the outside into politics, they don't necessarily realize that there's a lot of lawmakers like yourself who have a history in medicine. How has that background, and you sort of touched on it already, but how has that background helped you craft pieces of legislation and really move forward on healthcare, obviously a policy area where there's so much to debate?
So real-world experience makes a big difference. And so whether we're talking about raising Medicaid reimbursement rates to match Medicare so that more kids have a medical home so they get care from their own doctor instead of in the emergency room, that's the right thing to do, and it makes dollars and cents. Whether we are talking about women's access to reproductive health care, even whether we're talking about screening for type 1 diabetes, if you think about real world, it helps you make laws that make sense.
So, we're in an interesting era here in Washington. It's been certainly an interesting, 2.5 months. Talk about sort of what your work has been like in Congress in the age of DOGE, as you're seeing these cuts to a number of, the NIH, healthcare areas. How has that impacted your work?
So I will echo my colleague Diana DeGette in saying nobody wants waste, fraud, and abuse. I will also say that we could learn a lesson. No, DOGE could learn a lesson from carpenters who measure twice and cut once. That you got to study first so you know where the fat is and you cut that, or you know where the duplication of efforts is and you cut that. And frankly, sometimes improving efficiency means you hire up more. It's not always just taking a chainsaw. And I think that now the country is learning in real time, and frankly, I think the administration is learning in real time what it means when you just take a chainsaw to the programs like Bonneville energy that keeps the lights on in the entire Northwest. You take a chainsaw to, no pun intended, to the Forest Service that thins our forests, prevents catastrophic wildfires, but also brings in the timber that we can use to build homes. And if we can't build homes from the timber that the Forest Service brings out of the forest, then we're now buying timber from Canada at a 25% increase in cost. So I'm trying to connect all these dots. I hope they are too.
You know, there's also been cuts to NIH, you know, that will certainly impact research. If you could go into some of the consequences of that.
This is disastrous, what's going on with NIH, and I'm just going to share a couple stories. I live just outside Seattle. We have some of the preeminent research institutions in the country. And, you know, just the pauses, like, let's even stand back for a moment from cutting the indirect costs, and I'll get to that in a sec. But just the can't communicate, can't fly anywhere to meet means that grant programs couldn't be considered. And when I think about Seattle Children's Hospital and I think about Fred Hutchinson Cancer Research, they're in the middle of studies right now. If they have to hit the pause button, then let's say a woman who is in a study of a chemotherapeutic agent to cure her cancer, she can't stay on schedule to get her next experimental treatment. That just blew up the whole study. The study is now invalid because they couldn't stick to the protocol. Like, I just want to make clear that has now killed the study. It's also meant that a lot of students are choosing not to go into this, and that a lot of medical schools are not bringing in more MD, PhD students and fellows to do research because they have uncertainty about the future. And then I also just want to point out that there's been language used very strategically by this administration. First of them is probationary, which sounds like you're in trouble, but it just means you've been working for the government for less than a year. Okay, the other one is indirect costs. I had to look up what that meant. You know, like they said, we're just going to cut indirect costs and you can't have more than 15% indirect. Because to all of us, indirect sounds like slush fund, right? It's not. Indirect just means that it's not paying for exactly the researcher's salary and the exact tools that are used in that particular study. But if it's like a building that many studies and research facilities are using, if it's the lab that multiple studies are using, if it's the MRI machine, the infusion center, you name it, if it's used for more than that one study, that's called an indirect cost. So when you look at some of the research institutions in my state, their indirect costs are like 50%, 70%, which doesn't mean it's half of the money. It means for every dollar on research, it's 50 to 70 cents for the other stuff. But that's not fat. Like, that's necessary. And by doing this, you're going to kill medical schools, you're going to kill research in this country, you've already damaged all these studies, and you're ceding this ground to China. And I don't know, the vaccines developed here by far exceeded what Chinese scientists came up with, and I think we need to respect and continue to infuse our country with the preeminent research in the world.
It's a really good point you made about students. I mean, so you're seeing that morale is low among students looking to go into health.
Going to research right now.
Yeah,
yes. I mean, also, if the committees can't meet and like the PhD students can't present what they'd like to research, then they're not offered positions. So now what are they going to do for this next year? They got to find something else. And if they find something else good, are they going to come back to research? I just don't know. And or are they going to go overseas? Let another country, you know, take advantage of their brilliance, and we lose. This is an America loses proposition to cut research.
So what's your advice to those students or young professionals looking to go into research and, you know, coming up against these roadblocks in many ways?
I mean, first, I would just express gratitude to them for their commitment to advancing science. I would express my sympathy and shared frustration about what's going on in this country right now, and sort of an anti-science mindset and a recklessness. I don't know what my advice would be. I think like right now this is going to be in the courts, but this is already having cascading effects here. And I think we need to understand, again, let's go back to that woman's study with cancer. They got to start the whole thing over again. Okay.
Congresswoman Kim Schreier, thank you so much for joining us today. We appreciate it.
Thank you.
Yes. Oh, very good to meet you. Yes.
In a moment, I'm going to introduce you to an incredible individual with an absolutely amazing story. He is the president-elect of the American Medical Association, and when you hear his story, it will send a shiver down your spine. This is a story from the Saginaw, Michigan station in his home state of Michigan. The story of our next guest, the incoming president of the AMA. I direct your attention to the monitors.
2024 was a year of incredible joy for the Flint physician and his family.
Medicine is what allowed my parents to come to Flint, Michigan back in the early 1970s. So it's just a nice way to give back to the profession that has given us so much.
In June, he made history when he became president-elect of the American Medical Association. He says it was the first time he'd ever seen his dad cry.
Having come here as an immigrant physician at the age of 25 and within a generation have his child be the first president of the American Medical Association of Indian origin was something that brought tears to his eyes. And so tears of joy at that moment.
Less than 6 months from that moment, Dr. Bobby would watch his dad weep for the second time.
But no longer tears of joy, but tears of despair when he, as a radiologist, knows exactly what he's looking at.
The image on the scan that caused his dad to cry revealed an 8-centimeter tumor, a glioma grade 2.
It's a tricky area because the outside part, the lateral surface of the temporal lobe, is the language center of the brain. And because I'm right-handed, I'm left brain dominant, which means that the speech center, my ability to speak and have this conversation, is very dependent on that portion of my brain. And so we have to go, the surgeon has to go through that portion of the brain to get deeper, which is where the tumor is, to start removing that.
A surgery that he will be awake for and could take up to 12 hours. Only time will determine how life will change for him on the other side of the procedure. But in the days and hours leading up to it, Dr. Bobby is being fueled by love.
Please join us in welcoming Dr. Bobby Mukamala, the incoming president of the American Medical Association. Wow.
I said, well, when I saw that video, too. I haven't watched it in a while, but that was pre-surgery. And so a month after that was when I was at the Mayo Clinic for surgery, and here I am 12 weeks later.
And that, I mean, you think about it.
Thank you.
Let's just talk about you for a moment. The timeline in all of this, you are reaching the apex of your career. What is happening? What did you notice going on in your brain?
Yeah, so I was giving a speech to a group of physicians that have known me for more than a decade, the Minority Affairs section at the American Medical Association. And we were in Orlando in November. And during
Last
the speech,
November.
Yep, just this past November. And I was 53 at the time. I'm 54 now. And for a minute there, I sort of lost my point. And I thought, okay, 53, this is what a brain fart must be like. Well, the reality was everyone thought I had a stroke. And so immediately, the chair of the board and my wife meet me right outside that room, and they said, we think you've had a stroke. You need to go to the emergency room. So I go to the emergency room, and the vitals are fine, and they thought, okay, well, maybe I have a TIA. They said, you're fine to go home. When the meeting's done, just get an MRI scan. So I get home, and that night, I have a neurosurgical colleague, and I said, hey, I need to get an MRI scan to make sure it wasn't a stroke. Maybe it was just a TIA. Well, I get the scan done, and as I'm looking at the computer things pop up, the assistant there is saying, oh, you've got a crooked, deviated septum. And in my mind, I'm like, yeah, but I got a big-ass tumor in my brain that's right over here. And so I immediately called my dad, who's a retired radiologist, and we went through the images together on WhatsApp. And then I got my wife at home and my mom on the phone in India and my kids who are both now in college age or just past college. And it was a moment of just complete sorrow. Oh my gosh, what's happened? And I've got sort of a Spock-like mentality, I guess, which is, okay, what do we do next? Mm-hmm. And so I paused my wife's crying and my mom's crying and my dad's and kids' sort of disaster, and I said, what are we going to do next? And then it was off to the races. And that's when I realized how lucky I was within healthcare in this country to, within a matter of days, have appointments with the top neurosurgeons in the country to give their opinion about what they would recommend, and then within a month get that operation, and now be here speaking before you. But the main thing that got to me was that if I was a neighbor of mine in Flint, Michigan, blue-collar town, not exactly the top of the list of places to live or access to healthcare, a neighbor on either side of me would still be waiting for the prior authorization, for a referral to a neurosurgeon that's even comfortable doing this operation, let alone doing an awake craniotomy for 12 hours. The access to care in our country is like this. And I don't have an expectation that it's going to be like this, but we need to close that gap. And so I'm honored to be able to be at the organization to make that happen.
I want to come back to that. We want to talk about what the AMA is doing, but a normal person, and you are an expert in your field, might have just dismissed it and gone on with life. At what point would it become even more serious?
Yeah, so this thing was 8 centimeters, so it was pretty big. If you look at my post-op MRI scan, there's a big piece of brain missing, so I'm dumber, but I'm happier, is what I tell my patients, and they love hearing that. But if it
humble at every turn.
No, but if it would have grown, it would have probably caused. So as it was caused. That was a seizure activity, right? The speech issue that I had giving that speech was a expressive aphasia. It was a seizure, and so I'm on seizure medication now, so it won't happen again this morning. Don't worry. But as it grew, it would have affected more and more. As it was, the midline was shifting, but it's a slow-growing grade 2 cancer. Which the best news of all of this was that, because it's not grade 3 or 4, I don't have to get radiation and chemo right now, that I'm eligible for a brand new medication that I can take that could prevent the growth and maybe even shrink the last 10% that they couldn't get out. And my life expectancy, instead of being 10 months, is 10 plus years. And that's the science behind it.
And you are on medication now for the rest of your life?
I'm on anti-seizure medication right now. I'm supposed to be on the anti-cancer medication, but 2 weeks ago it caused my liver enzymes to be higher than ever, so they paused that. And they said, don't worry, it's not going to grow that fast, and we're waiting for the enzymes to come down. But this is an amazing experience. After 25 years of practicing as a physician, and now leading the physicians organization as its president come June, and president-elect right now, I think it's amazing that the 6 months before I'm inaugurated as president, from basically December until this coming June, to have the experience as a patient at death's door and navigating through the healthcare system. I mean, if you believe in somebody up there, I think that this has to be planned, because it gives me the experience to not just lead as a physician that's as close as you can get to a patient, because we interact, we tell people about their cancers and their tumors, but now being a patient that navigates the system, that fills that gap in knowledge between being a physician and being a patient, is enormously beneficial to advocate for healthcare in this country.
We are not done yet, but that deserves some applause.
Thank you.
So, final question on your condition, because you're in Washington, D.C., Beau Biden, John McCain, Ted Kennedy all died from a form of brain cancer. Is this different from their cancers?
Well, it is a cancer, but it's grade 2, right? It could have been grade 3 or 4. So mine was slow growing. It didn't enhance on an MRI scan. So in that sense, the prognosis is different, right? Instead of 10 months to live. And we didn't get that answer for about 3 weeks after surgery. So I left the Mayo Clinic where I had surgery, and an amazing experience on post-op day 5, flew home, barely remember any of it. I was kind of an ass in my behavior because 1 hour of sleep every night, but my parents and my kids and my wife still love me amazingly. But yeah, so 3 weeks later, we get the final pathology. At 6 in the morning, my wonderful chemo doctor basically called and said, at 6 in the morning, wonderful news, this is grade 2, you've got at least a decade to live, we've got some new treatment for it. So it's in the same category, but grade 2 versus grade 3 or 4.
Wow. So at the age of 54, your view of life is what?
this is bonus time. You know, this is time that that before all this happened, I thought, okay, well, you know, the statistics are where I live, you know, my family history, my underlying health, I'll be 90, maybe more. Now, 65 sounds great. You know, I mean, that's a decade of being so useful to my family, watching my kids get to that point where they will have spouses, have kids perhaps, help my community, spend a year, you know, 2 years as president and then past president at the American Medical Association, just trying to leave the world a little better than I found it, right? And that's my goal, and now that will happen, and it's a wonderful use of bonus time.
Well, we hope it's many, many more years than that. But let's talk about your work. Yeah, we can applaud. How do we break down that disparity that you talked about before, and how do we ensure that people who need good health care get it?
Yeah. I mean, the disparity is something that just shocks me. And honestly, we live in the city of Flint. When I leave my home and drive to my office, and I think about what my neighbors are being diagnosed with, and the hassle factor of things like prior authorization, just to get their insulin for lifelong diabetes, or treatment for their substance use disorder, which is a big issue, right? It's 100,000 people in this country are dying every year due to a substance use disorder, and yet prior authorization for something like buprenorphine, which is a fantastic way to get them off of a more dangerous opioid, those are hassles that we shouldn't have to deal with, right? And so that's what motivates me to work on those things on behalf of the American Medical Association. And then even access to physicians, right? My mom's a retired pediatrician. She practiced in the Flint area for her entire career. And she in her office had 2 people the entire time that she worked, right? One that was doing check-in, one that was putting patients in the room, cleaning up the room afterwards, and her. Now my wife and I share an office. My wife's an OBGYN, sort of an odd combination.
Well, it really runs in the family.
It's kind of an odd combination. I do earwax, she does pap smears, but we're in the same building, and it's hard to explain until they realize that we're married. But we have 4 people each just managing healthcare because of things like prior authorization, right? And that takes time away from patient care. And those are the things that I would like to work on. You know, the fact that we have electronic health records, and I'm spending my time literally as a typist, right? I went to medical school, 5-year residency, 25 years of practice, and I'm spending time staring at this computer screen typing, trying to type without looking, but I'm not that great of a typist. But instead of engaging with my patient, telling them about their larynx cancer biopsy that's positive, right? They need me. The computer doesn't need me. But yet, this is what I have to do to document. And then the worst thing about that, you know, so my wife being an OBGYN, she does robotic surgery, right? Fantastic gynecologic surgery using a robot. And yet, when she gets back to the office and needs to let the primary care physician know how things went, she's literally faxing the op note from that robotic surgery to the primary care physician because of a lack of interoperability of the healthcare record.
Faxing.
Faxing, right? So, I mean, I joke, but it's totally true. I said it at the Consumer Electronics Show. It's like being George Jetson and Fred Flintstone at the same time, right? And there's a certain generation that knows who those people are. The rest of you, go ahead and Google it. But it's literally cutting edge and dinosaur age era at the same time, which is totally inexcusable.
I'm curious, how many patients a day do you see now, and has that changed in the last 6 to 8 months?
Yeah, so I used to see, the American Medical Association takes some of my time, and so I started to end earlier in the afternoon so I could get on Zoom calls. But before the cancer surgery, I was seeing about 45 patients in a day. And now, instead of 8 per hour, I see 6 per hour because I don't want to push myself so hard that it's affecting my ability to take care of patients. And so I have 10 minutes per hour that I come back to my office and just rest, because I don't want to be incompetent. I don't want my patients to feel the consequences of my brain tumor. I want to take good care of them. I don't want to sacrifice their care because I'm pushing too hard. The problem is that as it is, I see patients faster than the other otolaryngologists in town. I used to get them in within 2 weeks. Because of the physician shortage, it takes 6 weeks to get in to see me. It takes 3 months to get in to see other people. Patients are at a consequence of what we lack, which is a nice physician supply to be able to keep people healthy. And that's something that's the other thing that's occurred to me. I had amazing brain surgery, right? But what about those people that have a psych issue, right? That have a substance use disorder, that have a mental health need, that are literally waiting in the emergency room on a bed for weeks looking for inpatient care for their mental health issues? That's a failure, right? Brain surgery, fantastic country to be in. Mental health issues, worst country to be in of developed countries. That's something we need to fix.
So with general care physicians, pediatricians, what kind of a shortage are we looking at over the next 10 years, and what can be done?
Yep. So we've got an 80,000 physician projected shortage just in the next decade. 80,000. Probably going to be more than that as time goes on. But that's because the funnel is the residency training, right? So we have twice the number of medical schools in Michigan than we had when I went to the University of Michigan for medical school. But the narrow part is the residency positions, because that was frozen in the 90s and really hasn't expanded. And so patients have to wait. What's the most interesting demonstration of that? When I first started my practice 20 years ago, I could get people in, on a regular basis, and maybe one person per month came to see me from an urgent care department, right, an emergency department, because they were between primary care physicians. Now, yesterday, before I got on the plane to come here, in half a day, I had 8 patients come and see me through the urgent care because they can't get into a primary care physician or they don't have a primary care physician. If we're going to get off the bottom of the developed countries list as far as our health as a country, we need to have an engagement with the physician and their patient to prevent disease instead of just dealing with it on the emergency basis and then scrambling to an urgent care to get a less than accurate diagnosis conveniently. That has to change, right? And a lot of that has to do, with compensation of physicians, right? The fact that when you look at, like if a hospital cost goes up, payment goes up to the hospital automatically. If it goes up 1.5%, payment from the government goes up by 1.5% in the Medicare program. When physician costs go up, Congress has to pass something to compensate for that. And usually it's a cut. So there's a 30% gap between what it costs to take care of patients in the outpatient setting to keep them from getting into the hospital and what we actually get paid. And that's just not a predictor of a healthier America, right? We need to prevent disease. We need to pay for the patients to get their care so they don't get sick. They don't have a diabetic ulcer. They don't have, a stroke because their blood pressure runs so high. We need to detect that and we need to treat that as an outpatient. But right now, all that investment is going for the cancer, for the stroke. What about prevention?
So what more needs to be done? How do we get to that point that we can prevent? One thing about HHS Secretary Kennedy, Make America Healthy Again, prevention is one of those tools.
Yep. So, certainly I think that in some of what he proposes is very reasonable, right? Nutrition, right? Access to healthy food, access to a place to get exercise. In Flint, in the city of Flint, where we live, if you're looking to go get exercise in a park, one, you got winter to deal with, and that's enough of a natural barrier. But when you have a lack of public space to be able to safely go and exercise, that's an inhibition of health. If you have to go to a grocery store and you're looking at crap food that's available and it's all high salt because it needs to be on the shelf for months because they don't sell it fast enough or the market's not there to sell the stuff they'd like to sell, those are barriers, right? And those are things that I think that RFK Jr. and I would agree on. The vaccination thing, no, we're not going to agree on, but we can discuss that if we build a relationship to kind of push for those things that we do agree on to keep people healthy. And then maybe chapter 2 or 3 of our conversation can be about discussion of those things that we're maybe on other sides of the issue of. And that's my foolish optimism. Maybe the brain tumor had something to do with making me optimistic because life has been wonderful, but that's what I'm looking forward to.
So I grew up along Lake Erie, so the joke is that there are 2 seasons, winter and 4th of July.
Yes, indeed.
2 final points we're going to go over just a moment, but my wife is a nurse at one of the largest hospitals in this area, and she said one of the biggest problems she is seeing, doctor burnout, physician burnout.
Yep. Yeah, so as it is, we have a shortage of physicians coming in. And then when physicians deal with the headwinds of things like prior authorization, of things like payment cuts, when I think about our office that Nita and I are in, it's just the 2 of us, everything that we earn goes to maintaining the office, keeping up with the increasing cost of having people to help us deal with prior authorization. We have people on the phone all day getting prior authorization. Those people, when we first started, were $10 per hour. Now they're $23 per hour, but we need them to take better care of our patients. And so eventually that's going to cause burnout. And people will be like, you know what, I was going to work till I was 75 like my parents did a generation ago, and now at the age of 60, they're like, you know what, I'm done. So we're not training enough people in residency, and people are leaving early, and what is that going to do for the health of our country? Nothing good.
Final question, because if you didn't know, you wouldn't know. You look great.
Well, that's because I asked them to seat me with this side of my head facing the audience, but the incision was right here. But all my bald friends were so jealous because they barely cut any hair, and they thought I was going to join them, but I didn't join them. But it's been amazing, and thank you for this opportunity.
And life is normal for you?
It's 90% there. Again, you know, the liver enzymes being high on this medicine, they're minor little bumps in the road, but relative to the patients I take care of and the cancer that I diagnose in their larynx, in their ears, in their nose, I'm a blessed person, and I'm glad to be able to continue to take care of them and have their perspective as we try to improve healthcare in this country.
You are an inspiration. Congratulations, the incoming president of the American Medical Association, Dr. Bobby. Thank you very much.
Thank you.
Just stay for a moment. Want to share with you, Julie Manchester had a conversation with Congressman Buddy Carter of Georgia. He's the chair of the House Energy and Commerce Subcommittee on Health. He had some constituent work back home, so unable to be with us in person, but we do have this conversation that was recorded. You can watch in the monitors.
Congressman Carter, thank you so much for joining us today. I want to jump into your role as chairman of the Energy and Commerce Subcommittee on Health. Obviously, it plays a big role in shaping healthcare policy and legislation. What are the committee's priorities so far?
The committee's priorities are basically to help Americans live healthier and longer lives. We want to improve our healthcare system. We're trying to work hand in hand with President Trump and with HHS Secretary Kennedy to see what we can do to make things better in our healthcare system. And certainly that's important. As a practicing healthcare professional, a pharmacist by profession, healthcare is extremely important to me, and the delivery of healthcare. I often say that whenever we talk about healthcare, it doesn't matter if you're Republican, or Democrat, or Independent. We all want the same thing. We want accessible, affordable, quality healthcare, and that's what we want to try to deliver on the subcommittee.
Speaking of Secretary Kennedy, we know that President Trump and Secretary Kennedy have established the Make America Healthy Again Commission, also known as MAHA. We know that they are focused on addressing chronic diseases, increasing price transparency, and ensuring affordable health care. So where does the subcommittee you chair, where does that fall into this commission? How are you guys working together?
We're working together. In fact, trying to make sure that we are having price transparency and to make sure that we are lowering drug costs and healthcare costs in general. There are a number of issues. One that I'm passionate about is PBM reform, PBM of the middleman. The president has spoken about middleman and made comments here recently about middleman and how they're not bringing any value to the healthcare system, but they're driving costs up. If you will recall, last session, we passed out of the Energy and Commerce Committee and out of the House of Representatives the Lower Cost, More Transparency Act, and we were able to get that passed, and that included a number of reforms to PBMs, a number of reforms to price transparency, which is extremely important.
I'm curious, a lot of these ideas seem like Republicans and Democrats, as you just said, would seemingly be on board with them. How much bipartisanship have you seen in some of these, ideas, like with PBMs, for example? Is there room to work more with Democrats on this issue?
Question about it. The Lower Cost, More Transparency Act passed out of the Energy and Commerce Committee unanimously. It had Republican and Democratic support, and I think that was significant. I would submit to you that when it comes to PBM reform, we have some Democrats who are as passionate as Republicans are about that issue. Everyone has a pharmacy. Pharmacies are the most accessible healthcare practitioners in America, and And if we're going to have accessible health care, we've got to make sure that independent pharmacies continue to exist and that they're there. 87% of all Americans live within 5 miles of a pharmacy, making them, as I say, the most accessible healthcare professionals in America. That's why it's so vitally important that we make sure that they are able to sustain and that they continue, because accessibility, affordability, and quality of healthcare is what we're aiming to achieve here.
And you have such a unique perspective because you're a former pharmacist. I guess, how does that experience help you in, pushing through or, advocating for a number of these reforms? And, when it comes to some of these predatory practices we've talked about, which ones have you witnessed and which ones are, would you like to obviously prioritize tamping out?
First of all, I'm still a pharmacist. I still have my license. I'm not giving it up for this gig, that's for sure. But anyway, but no, I did practice pharmacy for many years, and I was the one who had to go to the counter and tell the senior citizen how much their medication was and watch them make a decision between buying their medication and paying for their groceries. I was the one who had to go tell the mother how much the antibiotic was for her child and watch her in tears as she tried to figure out how she was going to pay for that antibiotic. I set as my goal and to make sure that we did something about drug pricing. It was high for everyone. I never went to a counter and asked them, are you a Republican or a Democrat? All I knew is that prescription drugs were high and they need to come down, and we can bring them down if we have more competition. And that's what we're trying to achieve in the subcommittee, is more competition and making sure that we have transparency so that we can recognize where the problems are. I would submit to you, if we had more transparency in the healthcare system, not just in the drug pricing part of it, but in healthcare in general, that it would lead to lower costs for all patients.
I want to shift gears and talk about the maternal mortality rate. I know you co-sponsored a bill, the Preventing Maternal Deaths Reauthorization Act of 2025. Georgia, your home state's maternal mortality rate is among the worst in the country. How will this legislation help mothers in Georgia and across the country?
Well, first of all, you're absolutely right. Maternal mortality is something that I've worked on ever since I was in the Georgia State Legislature, and it's baffled me, and I continue to be baffled as to why Georgia's rate is so high. But nevertheless, there's something we've got to address, and we've got to have the materials and the information available to our healthcare practitioners so that they will know what to focus on in the states. And we want to make that data available to them, and that's one of the things that this bill would do. It is very important for us to address this. In the United States of America, it is unacceptable for us to have as high of a maternal mortality rate as we have. And for the state of Georgia, it's especially unacceptable.
So why has the United States, I guess, fallen so far behind when it comes to maternal mortality? I mean, we're one of the most wealthiest countries in the world, if not the wealthiest. I mean, that seems pretty shocking.
And I agree with you, and it's something that, as I say, that I haven't been able to wrap my arms around and figure out why this is such a problem. It's maybe reporting is better here. I would agree with that, and maybe it's better in the state of Georgia. We are home to the CDC, and a lot of people say, well, you have better reporting there. Well, I still can't accept that as the total answer. Perhaps it does add to it, but we've got a problem. We got a problem here in America. We got a problem in the state of Georgia, and it needs to be addressed. And again, it's unacceptable for as you pointed out, one of the wealthiest country in the world to have these high rates.
I want to switch gears to another issue that, elicits bipartisan outrage as well, and that's the fentanyl epidemic in this country. You're the co-sponsor of the Halt Fentanyl Act. What does this legislation do in a nutshell, essentially?
Well, the Halt Fentanyl Act, which passed the House, and it is very important because it permanently schedules fentanyl and its analogs as a Schedule I drug, which means that the penalties that will go along with that will be more severe. And this is something that we had it temporarily scheduled, but it needs to be permanently scheduled, and we did that. And I applaud all of those who had a part in this. Look, fentanyl is infesting all all of our communities. It is not discriminatory against anyone, much whether it be a party or whether it be what color the skin you have. It doesn't matter. It is killing our citizens. It is poisoning our citizens. I had a very, very unfortunate experience. I was in a public hearing, and being a healthcare professional, I should know better, but I referred to it as fentanyl addiction. And a mother stood up and corrected me, as she should have. And she said, "No, sir, you're wrong. My son took one pill and he's dead. It's fentanyl poisoning." And she was right and I was wrong.
That's interesting because I hear it referred to so many times by so many people as fentanyl addiction. What do you think is being done to educate Americans on this and how it is poisoning?
Well, that's a great question, and that's something that we need to be working on. First of all, we need to secure our border. I applaud the Trump administration. We've gotten the most secure border that we've had in many years now, and everybody thinks when you secure the border, you're just talking about keeping illegals from coming across that border. But it's the flow of those drugs across that border that is investing in our communities. That's one thing. Now, the educational part of it is also very important, making sure that we have the tools available to let people know that, even one pill, a minuscule amount of fentanyl can be lethal and can kill someone. We've got legislation that we've got before us now, Sammy's Law, which would help us to have a tool in the tool chest on the internet so that we could identify certain words that would help parents understand and identify whether their child was involved in something like this before. So many of these drugs come off the internet and you don't know what they contain, and in many cases they contain fentanyl.
I want to jump back to PBMs. I know it's a topic you're certainly an expert in. I guess if you could delve more into how PBM reform could drive competition and lower drug costs in the long term.
Well, right now, what we have is vertical integration, where the insurance company owns the PBM, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. And we've got to bust that up. And if we can bust that up, if we can have PBMs that are not owned by the insurance company and that don't own their own pharmacy so that they're steering patients to that pharmacy, then we can have an impact and we can have more transparency as well as having lower prices. Because right now, they're getting rebates. These companies are getting rebates and they're simply pocketing those rebates. Those rebates need to be passed on to the patient so that the patient would pay lower costs for their drugs. That's the way that we can solve this problem.
So when we look to the Protecting Patients Against PBM Abuses Act, what needs to be done in order to pass that legislation ultimately?
Well, we have a commitment from the speaker and from leadership that these bills, that we had 4 PBM bills that were in the CR package back in December that unfortunately got pulled and that didn't go into effect. We have a commitment from the speaker that those will be put into the reconciliation bill. They will save us some money. They can be used as pay-fors. They'll save the federal government some money, but this will be an opportunity for us to get true PBM reform. It is not the end. It is only the beginning of PBM reform.
Speaking of PBM reform, and finally, Congressman, last year you sent a letter to the Department of Justice calling for an investigation into PBMs in the opioid crisis. Just wanted to get a sense of where the status of that investigation is.
Right now, the FTC, the Federal Trade Commission, is undergoing what they refer to as a 6B study to see the impact of PBMs on independent retail pharmacies. They've already come out with 2 interim reports, and hopefully will come out with the final report soon. We've been in touch with the new chair of the FTC, and he has assured us that this is one of his top priorities, and he's going to continue to have the FTC Commission look at this. We look forward with great anticipation to their final report so that we can get it to the Department of Justice, and the Department of Justice then will have the ability to do something about it.
Finally, Congressman, when it comes to, I guess, your work as a pharmacist and, drug costs and hearing about those drug costs from patients, I guess, do you have any particular anecdotes that come to mind, from your time working as a pharmacist about the costs of drugs and how Americans are, if they're facing challenges getting the medications they need?
are facing challenges, and in many cases, it's because of the PBMs not allowing them to get the medications they need. We need reform to the prior approval process. We need to streamline that, make it quicker and more efficient so that patients don't have to wait on their drugs. We need to make sure that that when a particular drug is ordered, that patient can get that drug. We need to look at a number of different programs. I would be remiss if I didn't mention the 340B program at this point. That's a program that has gone amok and that has evolved into something that it was never intended to be. It's a vital program for FQHCs, for federal qualified health centers, and for rural hospitals, but it has really gotten and grown to a point where it needs to be reformed again, and we need more transparency in it.
Congressman Buddy Carter, thank you so much for joining us today.
Thank you.
We are about the halfway mark, and so the good news is take a break, a brief 5 minutes, get a cup of coffee, your legs. Oh, I'm sorry.
A Cleveland clinic has developed an AI nurse that you cannot distinguish from a human being, that has diagnostics as good as any doctor. And we can provide concierge care to every American in this country, even those, the remote parts of Wyoming, Montana, Alaska, et cetera.
Okay, we're back. The coffee break is coming shortly, but Julia Manchester is back, and we have a terrific panel. Please welcome Tim Wong. He's the general counsel at Abridge, Dr. Bali Yahia, the president of Jefferson Health, and Ryan McPherson, vice president of commercial strategy at Cedar. Welcome.
Good morning, gentlemen. Good morning again, everyone. Thanks for sticking with us. I'm really excited for this panel, just because healthcare technology, I think it's something we're all pretty interested in, especially as we hear more about AI and that kind of a thing. But I just want to introduce you all to the group we have gathered here today. Starting with you, Ryan, and then we can go down. Tell us a little bit about your company and what you're trying to do.
Yeah, so Cedar is a company targeting elevating the patient's financial experience in healthcare. So we know that roughly 40% of Americans cite financial stress as negatively impacting their ability to heal or their medical condition. And so we're really out to help address that challenge that is pervasive throughout the country.
Dr. Yahia.
Thank you,
Yes.
and great to be here. I lead Jefferson Health. Jefferson Health is one of our oldest medical institutions in the country. We just celebrated 200 years of service to the community, and we're across New Jersey and Pennsylvania. We have 32 hospitals and thousands of clinicians and caregivers, and our commitment is to improve lives of all the communities that we serve.
And Tim?
Hi, everybody. My name is Tim Huang. I'm the general counsel at a company called Abridge. We are in the ambient documentation space, so we build AI systems that convert sort of a conversation between a provider and a patient and generate draft clinical notes from that data. And so we're launched about in 2018, and we are in about 100 different health systems around the country.
Excellent, excellent. You know, there's so much promise, I think, in health tech, but we know that there's a number of challenges facing the industry as well. Ryan, I guess we'll start with you, and everyone feel free to jump in whenever, but what do you think are the biggest challenges facing the industry, and what can Washington do to help?
Yeah, great question. And as somebody who's very much a subject matter expert on the financial experience, I dabble in policy, obviously. But I would just echo a couple of the earlier comments that have been made. You know, as there is a general pull, if you will, toward many healthcare providers investing principally in their electronic health record system, which are oftentimes significant investments to them, to their technology team, to their resources, et cetera. But we also know that oftentimes these electronic health record systems, while they're fantastic and terrific systems of record, are not necessarily at the cutting edge of, you know, from my company's perspective, the consumer financial experience, or oftentimes, you know, other dimensions of clinical and more direct care delivery. And so to me, you know, if I were to sort of circle one area that's been discussed, I would say really dialing into the interoperability opportunities that exist and introducing more standards for data exchange. That's a huge barrier, I think, when it comes to ultimately the way that patients receive care and the way that care is provided in this country.
Tim, I know you work in public policy and you're involved in that. What are you focused on as a part of your role?
Yeah, so we're very interested in the idea that particularly this kind of ambient technology is very interesting because I think we're learning all sorts of things about what happens when a health system implements it. And there's a lot of studies that we are involved in trying to understand that, but I think it really is kind of a collective effort to think a little bit about how sort of AI will shape healthcare delivery overall. And so, to your kind of earlier question, I think there's a lot of room to run in terms of thinking about how we bring together sort of researchers to kind of continually kind of improve our understanding of where this technology can be best used, but also what its impacts are.
Right. Dr. Yehia, you're leading or involved in a hospital system. How does AI get involved in that? And what's the future of AI, I guess, playing a role in the development of hospital systems?
Yeah, I think it's important to know that healthcare is both high tech and high touch. And so the thing that we work on a lot is you don't want technology to get in the way between a doctor or a nurse and the patient. You want them to help them. And as you've seen from some of the other speakers, technology sometimes has increased the workload and leads to burnout. So I always say we got to make sure that tech is working for our patients, for our doctors. Now, I think AI has a lot of promise to be able to do things that help patients better understand their health care, summarize their records, be able to ask the right questions. I think it can support caregivers, making it easier to do their jobs, including some of the exciting things that are happening in ambient. And then also, you've heard a lot of the folks talk about prior authorizations and the paperwork. And so can AI help us with the back office work? So we have been focused on those three areas at Jefferson, on helping the patients, figuring out how we can reduce the burden for our caregivers, and then helping us be more efficient in the back office of healthcare.
Yes,
and I think this is such a critical point, particularly on high touch. I think often when we talk about AI in healthcare, it's this big monolithic thing, right? Like what happens, what will you do when the AI arrives? But I think a lot of things that we're finding is just so much of this is built into what are people doing right now and how does the technology fit into that workflow? And I think it's a big part of the exercise.
Yeah, totally agree. I think the one other thing I would add is trust. Technology in healthcare, we've always been dealing with it. It was whether it's EHRs, virtual care, which a lot of folks didn't have comfort in, and now they're using more regularly. Remote monitoring, everyone has different rings and bands that are monitoring different things. And so how do we continue to build trust between the technology and the patient community? There is still a lot of skepticism about what is this AI? Who is this AI? Are they taking my information? And so healthcare is really built on a foundation of trust between doctors and patients. And when we introduce technology, we have to make sure that we bring people along to make sure that that it's trustworthy.
And when you talk about those bands, you mean like the Aura ring,
exactly.
that kind of thing? Okay, absolutely. Ryan, I think you were
Yeah, I was just going to echo, I think both Tim and Dr. Yehia have both mentioned very practical, where can you start that's just very practical? And from our perspective, again, from sort of a fintech and healthcare intersection, it's always amazing to meet with providers and health systems in this country and learn that, if you're a patient who has a $5,000 bill and you're a patient who has a $200 bill, quite often those patients are getting the exact same experience. Regardless of your ability to pay, regardless of your insured or uninsured status, generally speaking, I'm not trying to throw any shade to any healthcare organizations, but there's generally a blunt object being used to articulate a very nuanced concept. And so where we're investing a lot in from an AI perspective is actually saying, okay, we know this about this patient based on the number of patients' lives that we touch throughout the country from a financial perspective. How can we curate the right experience for them that feels much more empathic? So if they are a $5,000, what we call ALICE patient, asset limited, income constrained, but employed, choosing between paying a healthcare bill and paying, for example, a utility bill, we either steer them toward coverage that's aligned with the health system's financial policies, we steer them toward pharmacy benefits that are often significantly underused in the country, or wherever the case may be. But there's very practical applications that, at risk of oversimplifying it for my engineering colleagues, are not the craziest use cases of AI that would have very immediate returns and just helping healthcare feel more human in this country.
I want to stick with that question, I guess, or that topic of cost. Obviously, the economy was a huge issue in the last election. We're still seeing a number of warning signs, particularly in this environment of tariffs and the impact those tariffs could have. But how, as a healthcare company, are you preparing for potential more increased costs, potentially the economic environment, and how do you think technology can help?
Yeah, I mean, for us, again, being pretty singularly focused around the patient's dimension of this care, I would say it's a couple of things. Number one, we know that a significant amount of aid in the form of existing, for example, health savings accounts that many high deductible health care plan enrollees have access to go underutilized or unutilized on an annual basis. And so we're doing a lot to build and connect different sources of financial assistance and financial support to patients and provide them in a way that ideally saves on the administrative cost. Right now, many healthcare providers are attempting to engage patients in a pretty manual, labor-intensive way. And so we see a lot of opportunities to bring, again, sort of applications of the consumer experience from retail and other industries into healthcare that ultimately can bring a lot of cost out of the system.
Right. Dr. Yeha, what are some of the biggest wins you've seen in your experience, particularly when it comes to AI?
Yeah, I think we have about 100 different AI projects and tools that we're deploying within the system. A couple areas. One is on the patient care front. AI, if you recall, really got some of its origins with images and pictures. They're really good at that. And so when you think about radiology, which is those doctors are in front of x-rays and CAT scans and MRIs reading images, we have deployed a lot of tools that makes it easier for them to identify, hey, there's something wrong in this part of the scan. Same thing with radiation oncology, where we now are able to better design treatments and reduce the side effects for our patients by using AI. We are deploying Ambient, which I've received just rave reviews from our doctors on that, allowing them to not only spend time looking in the eyes of the patient in front of them, but don't have to go home after work and chart. And my partner's a GI doctor, and typically the dinner table is some food and writing notes. And so how do you get back a semblance of that life? So I think there's a lot of exciting things on the Ambient front. And then we're also doing a lot of things around how do we create a better, safer, and higher quality care within the hospitals. So we're using AI to help us figure out, is someone more at a risk of falling in the hospital? Or is there a way that we can better identify various risk factors? So we're using all those different things to make healthcare safer and higher quality.
Tim, I think there's a lot of excitement when it comes to AI, but we know that there's a lot of chatter about regulation going forward. And I know that you've worked, with the White House on this issue. So what does the move to more AI regulation look like, particularly for health tech?
Yeah, definitely. I think it's a really interesting, evolving environment right now. I think one of the interesting conversations I had recently was with a legislator in New York who said, this session I'm introducing 20 AI bills. Yeah. And I was like, so why are you doing that? And he's like, I just want to make sure we cover all the bases. And so there's just so much state level activity happening around AI at the moment that I think one of the really interesting questions in policy to be worked out, in the coming months and years will be, what is the balance of kind of health and AI regulation on the state level versus the federal level? And I think that will be like one of the really interesting questions as a matter of like how much we want to localize in terms of the deployment of these technologies and how much do we want to have sort of national policy around.
Have you all ever gotten pushback from patients or consumers over developing technology? I mean, like I said, a lot of excitement around AI and, some of these new things, but when it comes to your health, I mean, there is, maybe some skepticism when it comes to that.
Yeah, yes. I think a lot of that gets back to what I was showing about trust and opening the doors for folks to understand the technology. And this, like I said, has happened in time and time again in healthcare. Every couple of years, there's something new that's introduced. Right now, it's AI, remote patient monitoring, virtual care, you name it. It's happened before, and we got to make sure that this technology, AI or whatever it is we're using, works for all patients. And I think that's really important. And so we have invested in health literacy, which is letting folks better understand all the tools that are available to them, connected care. And so that is the one thing that I focus on a lot, is making sure that we continue to have access, equitable access for these technologies to all the communities. As I mentioned, we're across Pennsylvania and New Jersey, so we've got rural communities, we've got highly urban communities, and everywhere in between. And people's use with technology is different. Their access to Wi-Fi is different. And so figuring out how do we make sure we bring patients along is really important, because healthcare is very personal. And when you start introducing other things in there, like technology that folks don't trust or don't know, we don't want them to deter from actually getting the preventative care and the treatments that they need.
Yeah, I'd love to build on that trust theme. I mean, I think in some ways, Bridge doesn't think it can sort of succeed without earning that trust in a lot of ways. And, I think to give an example, I think we're going to be continually asking the question of just like who AI serves in this whole system. One of the features that we're very proud of that I'd love to kind of talk about is a feature that we call linked evidence. So the notion here is that you can imagine building an ambient solution that just takes the audio, generates the note, and then that's it. It's all done. But I think listening to a lot of the folks that use our product, right, the question is, okay, well, what about this note is connected to what actually happened in the appointment or the encounter? And so we've kind of developed a feature within the product that allows you to sort of select, say, this part of the note, where does it actually come from? What are you basing these judgments on when you summarize down to a note? And it's been sort of enormous for the trust of the product, right? And I think, again, that's almost entirely sort of a feature you build, but it kind of asks the question, right? Who's the technology serve, and how do we generate like a relationship with trust with the tech you're implementing?
Right. Ryan, do you?
Yeah, I mean, I think a lot of the sentiment that's been shared is spot on. I think, using voice of the customer or voice of the patient to guide product making decisions and where you're going to place strategic bets is really important. Another role that I have at Cedar is that I work very closely with our data science team and run our analytics arm. And one of the things that we use a lot of our data and our findings from is to actually help, frankly, address bias that many healthcare leaders probably have. All of us carry, preconceived notions of a given demographic or whatever the case may be in terms of technology adoption. And so what I would just say to add on to it is that we try to, as best we can, really arm our customers and the providers in this country with data to actually help them make more informed decisions about it rather than going with gut or the shiniest new, application of technology, wherever the case may be.
It's sort of fresh on my mind as it is with a lot of people, the, 23andMe, the, sort of future of that data. A lot of people's personal data is involved in that. Is there, from patients and consumers, is there, concern about if they're using these technologies, where does their data go? I don't know how much you can speak to that, but it seems like it's kind of relevant in the conversation.
Yeah, happy to jump on that. Yeah. I mean, I think that one of the really interesting questions, so there's obviously a lot there, right? And I think there are all the usual things that we believe companies in the space should do, right? You should have good safety practices, you need good security, all those things need to be in place. I think one of the really kind of key issues, which is at least unique to AI, is sort of the use of that data to kind of improve AI products, right? And this is a big part of the sort of kind of flywheel of data-driven innovation. And I think we're actually really committed to the idea that you can actually get all of these improvements through de-identified data. And that actually the kind of classic trade-off in the space, which is, well, you have to give this data so we can improve the product and you benefit from that product. We're actually kind of making sort of basic science improvements, right, that allow you to say, well, look, the data can be de-identified before it's even used for improving these AI systems. And that, I think, changes the sort of fundamental kind of economics and sort of kind of social contract that has emerged around these technologies to date.
Absolutely.
I think, too, we are so dependent on information and our IT systems and data. And the other topic that's really important here is cybersecurity, which is a top priority for healthcare across the country, especially big organizations like ourselves. I mean, we have, along with many other systems across the country, every day there are people trying to get into the system. And that's not something that happened, 10 years ago, 20 years ago, 30 years ago. And not only do we need to make sure that data works for our patients and our communities, but we got to find new and more creative ways to protect that data because there are a lot of bad actors that are trying to not necessarily go after governments, are going after the public institutions like healthcare and hospitals that are anchors in communities that take care of a lot of people and have a lot of sensitive information. And so that's something that we're keeping a close eye on, is how do we continue and how does maybe AI help us continue to evolve and protect the data that we do have.
Ryan, you run commercial strategy for Cedar. What's your strategy to get Cedar in as many places as possible?
Trying to events like this. No, in all honesty, this is, we mostly deal with the administrative arm of healthcare, right, in terms of the people who typically purchase our services. So to me, it's just making sure that we are doing everything we possibly can to take every opportunity to get the word out on the importance of, we've sort of begun to talk about this concept of preventative financial care. Like there was a lot of conversation earlier today about getting primary care is increasing access to primary care and preventative care. We see an analog to that on the financial spectrum, right? We know that many patients are coming in and seeking care due to stress, and one of the top cause of personal stress in this country is personal finance. And so we don't think it takes too much to really squint and see the connection between people being worried about the bills they're going to pay and the care outcomes that they're ultimately going to receive. And so we see that. We know that there are hundreds of billions of dollars sitting unaccessed to help people afford their bills. And then we see things like, obviously, some of the policy changes we're talking about with Medicaid disenrollment. I live in the state of Georgia. We have certainly a Medicaid challenge there. And we just see an immense opportunity for a technology-first solution that helps connect all these disparate dots. If you are a healthcare provider in this country, you can be doing the best thing to provide this consumer experience within your four walls, but patients are still getting EOBs from their insurance companies if they're fortunate enough to be insured. They still don't understand how to navigate all the financial complexities. They're getting a bill from an anesthesiologist who saw them in their surgical suite that they don't understand why they're getting a separate bill for. And so we just see a tremendous amount of opportunity to demystify that, build trust, and the organizations that we're fortunate to work with, around 50 or so, many of them are very proud of their EHRs and different pieces like this, but we see a real opportunity for organizations like us that are very specialized on one specific function with a more interoperable environment to really help those organizations thrive and further their reach.
You talk about demystifying and, I guess, building trust with those patients. I guess this is a layman's question, but what does that look like? I think it's when patients get a bill, a lot of this stuff is very nebulous. It goes right over their head. How can you further, I don't want to say educate, but give them that information?
Yeah, I mean, to me, again, I'll speak briefly, and I'm sure other panelists have a thought, but to me, it's all about the outcomes that you measure. Again, I mentioned I run our analytics team at Cedar, and we're very proud of having a net promoter score on par or exceeding many of the leading consumer retail brands for the clients that we serve, which tells us that we're doing something right directionally. One of the things that we're doing a lot on right now with provider organizations is really helping them understand the outcomes that they're currently delivering, so that many of them can tell you their quality scores and different pieces of that. They can't dimensionalize that through a patient's financial experience. And so we've begun to lead an effort around the country to really launch a benchmarking initiative aimed at helping healthcare providers understand the patient's outcomes from a financial perspective. So how many times do they call you with a question about their bill, right? Something as fundamental as that, many organizations have absolutely no idea what that ratio is. And so it starts small, and then we think there's a lot of opportunity to continue to press in there and further educate and build trust.
Absolutely. Moving on to, we only have a few minutes left, but I want to get a sense from all of you, sort of what's something that's on your radar, doesn't have to be from your own companies, that you're excited about and we should all keep an eye out for.
Sure, I guess I'll name a few things.
Yeah.
I mean, I think to build on this theme that you're just talking a little bit about, AI is like a very nerdy space. And I think the last few years have been very much like the invention of the combustion engine, right? Everybody's excited about the engine. And then now I think we're now entering the era which is okay, but what do we do with it? And I feel like there's been so much obsession about the AI when the bigger thing has been what can it actually do for you? And a lot of this is actually you can put the engine in a car, it can drive you somewhere, right? We are talking more about outcomes and almost the interface, right? Kind of people don't care about the AI, they care about whether or not they're having a good experience. And I think that is a real change in the marketplace that is influencing not just Abridge, but AI companies across the board. So you kind of look at, within the AI space, people are oh, well, there's Anthropic and OpenAI. And they used to compete on, oh, well, our AI is the most advanced model. But now a lot of people are well, this one's better because the interface is better, right? And I think it's a shift that's influencing AI kind of across the board. And it's very, very interesting to see is that kind of the rise of kind of design in the space is becoming more and more important.
Right. Dr.
I would say two things. One is the new therapies that are coming down. And I think it poses different challenges. But just this week, we got approved to use new cellular therapies for sickle cell, which is if you've known anyone that has sickle cell disease, it's a very painful and challenging disease. And now there's therapies that could pretty much create a near cure. Now, these come at the cost of millions of dollars an injection, but we are on the brink of some really amazing breakthroughs in cell and gene therapy. And it's very exciting. It's a very exciting time for in healthcare in these areas. It does create some issues on the healthcare financing side that all of us are going to need to figure out how to do, but it's super, super exciting. And then the other is we have seen now a more, I would say, respect for community-based and home-based care. And we are using in our system a lot of community healthcare workers, which are individuals that are from the community, that know the community and are helping those community members achieve healthcare. And so, you know, healthcare for us is not within hospital walls and clinics only. It's within homes, it's within community centers, it's within mobile vans driving around. And the more we think about that, I think the more we can reach people that sometimes have been hard to actually get into the healthcare system.
Ryan.
Yeah, I mean, I was going to share a couple of the thoughts that Dr. Hia just mentioned, but I think one is, I talked a little bit earlier about interoperability. I think if we can, from a policy perspective, really move the needle on it, and requiring standard ways of exchanging data, that's so like completely uncool to just talk about nerdy stuff like that, but there's very real practical applications that ultimately impact patients and their ability to access their own information and their ability to navigate the healthcare system in a seamless way that I think would be, there's a lot of opportunity from a policy perspective on. And then I have a couple close friends who work in some of the nation's hospital at home technology providers, and I think that we've really just begun to scratch the surface in what that's capable of as well. And when you think about moving care out of these large brick and mortar high cost areas and really pushing the envelope on remote monitoring and some of the things that Dr. Ihi had mentioned as well, I think we've really just begun in that space.
I feel like telehealth is a whole other conversation. Yeah. Such an exciting space. Gentlemen, thank you so much for this conversation. We'll be looking forward to see what you do next. Thank you.
Thank you.
We're going to go that
way. The panel, great job. Did I mention a coffee break? So coming up in just a couple of minutes after a brief break, Mark Cuban, our conversation with him, yes, that Mark Cuban, former HHS Secretary, Kathleen Sebelius. If you're watching online, continue, because Joseph Choi, healthcare reporter, Alex Gangitano will basically break down what we've learned so far. And a reminder for those of you in the room and watching, the hashtag is The Hill Health. So we'll be back in just a moment or two. Thank you.
Well, thank you all for still being a part of our live stream. We're so excited about how this event has gone so far. I'm Alex Cantitano.
I'm Joseph Choi. I'm one of the healthcare reporters here at The Hill.
And we wanted to discuss a little bit about what we've been hearing so far and what we can look forward to this morning. So what's been some of your biggest takeaways?
So one of the major takeaways we've seen this morning is that across the party lines, across private sectors, across nonprofits, people have a shared goal of addressing these healthcare issues. We've heard people discussing, we heard from Dr. Mukamala, and we also heard from some of the lawmakers that they want to address issues like administrative lag or so much paperwork and digital issues. These are common issues that people want to tackle, but these things get caught up in Congress. But there is attention to these common issues, and there's legislation targeting these things, but it's slow going.
Yeah, it did seem like there was some concerns over the lack of bipartisan consensus on some of these things, just in terms of having a conversation. As you mentioned, people are on the same page, it seems, but the conversations on Capitol Hill aren't happening. And it was a lot of the Democratic members of Congress blaming Republicans, of course, for that, whereas I'm sure vice versa would happen as well. But for Republicans being more focused on things like the tax bill than looking at ways to improve our healthcare system. Something that I thought was interesting, though, from both Democrats, Congresswoman DeGette and Congresswoman Stryer, was also that they thought cuts to waste and fraud and abuse, those are all important things. That's what the Trump administration, Republicans are so focused on. But they stressed some concerns over, does that mean cuts to Medicare? Does that mean cuts to research and science? All these things that they were so passionate about being able to preserve.
Right, and Representative Stryer, she said something interesting. She kind of compared it to being a carpenter, and you want to measure twice, cut only once. And we've seen that these broad slashes across the budget, and it sounds like everyone wants more efficient, more streamlined work, and that's a common theme we've heard. But it sounds like for Democrats, if they're going to go along with this, they want it to be very targeted. They want it, and we've heard that from the private industry as well, that they want targeted cuts. They want cuts that make sense. And we've heard from Democratic lawmakers that right now they don't see that happening. From DOJ.
Right. And speaking of the administration, while we're on that, you obviously covered Secretary Kennedy's confirmation process very closely, and it was interesting how much he came up. There was just questions over, do you align with anything on him, to some of these Democrats? And they did have some areas of, preventive care, things like nutrition, things like feeding our children healthier things. But a lot of the concerns they had with him and the overall Trump agenda had to do with the fact that they're believing more partisan ideologies than science. And so I thought that was interesting. This MAHA agenda isn't something that people seemed super decisive about or indecisive about, but that they thought that, we can come together and take care of our kids in a healthy way, but we don't think this should be a partisan thing. What did you make of those kind of conversations?
Yeah, again, that's one of those bipartisan issues that people want to come together on. Of course, we want people to be eating healthier and practicing healthier lifestyles that maybe take less of the burden off of our healthcare system. But again, we've seen both across the aisle. We saw Senator Cassidy, who is the head of the Health Committee, this kind of departure from relying on science. RFK does not, even though he's been in the anti-vaccine space for a while, he's not coming from a scientific background. Right. And that seems to be the core issue, is that people want, these lawmakers and stakeholders, they want kind of a more partnership with science, and that might not be something we're seeing with these with Trump's healthcare nominees in the cabinet. It's a common concern we've seen both in Congress and among stakeholders here that, there's a lot of scientific research happening and a lot of great things happening, but whether or not that's integrated into the Trump administration's goals is a common concern. We've seen cuts or proposed cuts to scientific research, and we heard from one of the speakers today that, and I've heard from scientific researchers in the field that if these cuts do go through, China would be the number one, would take the spot as the number one country in terms of research. But as we heard today that, even if that were to happen, China does not reach the capacity that the U.S. has. So it would be, it would be a detriment to future research if that were to happen. So, that is what, that's something we're continuing to hear today.
Yeah, and another timely issue that was discussed was how artificial intelligence plays into this field. I thought that latest panel, some stakeholders, experts on this were talking about, you can't really replace human notes, they were saying we sit around our kitchen table at night and we write notes about what we learned that day, some takeaways, what research we need to do further for our patients. And it seems like they were open to integrating some of this new technology into what they do, but taking out any human element, it seemed to them to be a concern. Or what did you make also of that conversation?
Absolutely. There is a lot of excitement about integrating AI into the healthcare sector, but we've seen some hiccups. In these attempts to integrate it into healthcare. Something that interesting we've learned is that Trump's new CDC nominee to be director of the CDC, Susan Menares, who comes from ARPA-H, and she's actually spoken with the Hill before at our previous events. Yeah. She is very excited about integrating AI into healthcare. And so that seems to be another area where, hopefully stakeholders, lawmakers, and the administration can come together. But again, physicians have concerns about AI. Obviously, it's not an infallible technology. So it'll be interesting to see how that develops with this administration.
Yeah. Something I just wanted to touch on a personal note, Dr. McConnell, excuse me, his personal story I thought was so moving. I've had family members experience brain cancer, and it just to be able to hear from him of how positive his attitude was. He was saying, I have a decade, I'm living on extra time, and that he looks at this from a healthcare perspective of how can I learn from this for my patients. And I also thought his kind of two takeaways from that. One was that we should focus on mental health in our country a lot more. And another takeaway was to listen to your body. If you think something's wrong, you're the expert in that field. So I thought that was just a really moving conversation.
Yeah, and it was interesting. One thing he said was we are at the cutting edge, but in a dinosaur era. And that speaks to, again, he seems to share this, we want to update our healthcare sector to be more efficient. And hopefully that's something that, if the Trump administration is very dedicated to efficiency and cutting waste, fraud, and abuse, if we can cut down on waste of time in the, he's mentioned that he's having to, enter electronic records a lot of times, and that's a common issue we hear among physicians is they're spending a lot of time on administrative work when they'd rather be working with patients. And so it's interesting to hear his perspective, both, he is both a patient recently and a physician. And yeah, I agree. It was really fascinating to hear from someone like him. Yeah,
such an amazing perspective to be both the physician and the patient and just give people some hope that are in those fields, and also how he was pushing for, more research, more knowledge about all of that. We have some exciting panels coming up. I'm excited about the women's health in particular, to be able to have those really important conversations. And we are appreciative of all of you tuning in. Thank you for being a part of this, and enjoy the rest of the event.
Thank you.
could please take your seat, the program will begin momentarily. Please take your seat. Again. Ladies and gentlemen, the program will begin momentarily. If you could, kindly please take your seat. We will begin in just a moment. Thank you all very much. Ladies and gentlemen, the program will begin momentarily. Please take your seat. Our second half of the program, I'm pleased to welcome one of our lead sponsors, a good friend, the President and CEO of the Alliance for Aging Research. Please welcome Sue Peshin.
So a very special birthday is coming up this summer. On July 30th, Medicare and Medicaid both turn 60. That means Medicare will be only 5 years away from being able to apply for itself. And we're going to sing happy birthday. All of us are going to sing happy birthday. So look up from your laptops, whatever you're doing, join in. These programs are important. Happy birthday to you. Happy birthday to you. Happy birthday, Medicare and Medicaid. Happy birthday to you. Very good. All right. I think you guys have a side hustle if you need it. All right. So in the last 60 years, these programs have had an immeasurable impact. Today, Medicare covers more than 68 million Americans. 90% of them are older adults, and the other 10% are people with disabilities under the age of 65. The most significant growth in the program happened in the last 15 years, when enrollment ballooned by 20 million people. With more people, higher total costs come. That's why we often hear about the need to cut costs. But our hyper-focus on cutting costs overall might be clouding the original promise to be there for each person when they need it. Raise your hand if you've ever worried for you or your loved ones that you're going to hit access barriers in healthcare. And for those of you watching, it's most of the people in the room. And I'll tell you something, our fears are legit. In the last couple of decades, we've seen increases in utilization management abuse by Medicare payers and PBMs. They've been enabled by the Centers for Medicare and Medicaid Services' lack of guardrails. But this can be fixed, and this is what we work on a regular basis. This has also shown up in the narrowing of prescription drug formularies, more requirements for prior authorization and step therapy, and even attempts at differential pricing schemes. And this has shown up in Medicare coverage policies for treatments for heart valve disease, for cochlear implants, and for Alzheimer's disease. And all these types of policies challenge the FDA's biomedical expertise, and they ration care. And it's all under the guise of, we need to develop more evidence. And this has also shown up in overregulation of clinical care in nursing homes. We need to be careful, because what's happening is not only impacting Medicare beneficiaries, the private market follows Medicare's lead, which affects another 180 million Americans in group health coverage. We were pleasantly struck by how Dr. Oz answered one of his questions at the Finance Committee nomination hearing, and it was about utilization management. He said, quote, "That is one of the most frequent complaints physicians hear from patients is I can't get the treatment. I really know what works for me, but no one will give it to me even though I have insurance. I'm a beneficiary. I should be allowed to get access to this medication, which I'm told is in the plan, and yet it gets slowed down." End quote. What would it look like if we gave everyone the care they needed when they needed it? That's what the Alliance for Aging Research focuses on, changing the narrative to achieve healthy aging and equitable access to care. Now, of the 68 million people in Medicare, 1 in 5 are also on Medicaid. So I just want to be clear here. Any proposed cuts to Medicaid are, in effect, cuts to Medicare. If the proposed $880 billion in Medicaid cuts are finalized, states are going to have little choice but to cut optional benefits that aren't covered at all by Medicare and aren't required to be covered by Medicaid. So, for example, coverage of nursing home care for Alzheimer's is required under Medicaid, but home care isn't. Ironically, states may end up paying more per beneficiary for nursing home placements than they would for allowing people to live at home with home care support. And states with higher older populations, many of them rural, are going to be hit harder. We all need to step up and be thoughtful about how proposed policies are going to impact taxpayers. If we need to change these programs, let's do it, but don't take them apart. A lot of this is about how we value each other as human beings, no matter our age, ability, or our care need. After paying into the program our whole lives, we shouldn't have to worry or wonder whether we'll be able to get the treatments we discuss with our doctors and decide are right for us. 60 years ago, America made a contract with taxpayers to lift their worry and provide access to care as we age. If we get this right for older Americans, we'll get it right for everyone else as they age. And all of us are accountable to each other on this. After all, when all is said and done, all that counts is how we treated one another. And that's it. Thank you.
DJ's doctors believe his cancer likely came from a chemical he was exposed to when he was younger. Since 1975, rates of child cancer have increased by more than 40%. Reversing this trend is one of the top priorities for our new presidential commission to make America healthy again, chaired by our new Secretary of Health and Human Services, Robert F. Kennedy, Jr. Our goal is to get toxins out of our environment, poisons out of our food supply, and keep our children healthy and strong. As an example, not long ago, and you can't even believe these numbers, 1 in 10,000 children had autism, 1 in 10,000, and now it's 1 in 36. There's something wrong, 1 in 36, think of that. So we're going to find out what it is, and there's nobody better than Bobby and all of the people that are working with you. You have the best to figure out what is going on. Okay, Bobby, good luck. It's a very important job. Thank you.
Thank you all again. We should point out that we did invite the HHS Secretary, the current HHS Secretary, Robert F. Kennedy, Jr. We'd love to have him come back at any time, so an open invitation. Pleased to welcome a former HHS Secretary, Kathleen Sebelius, the former governor of Kansas. And of course, I should do the complete title, Kathleen Gilligan Sebelius. Your dad was the governor of Ohio. You are the first father-daughter combination to serve as governors of a state.
That's right. Different states.
Right. Ohio and Kansas. Welcome. We're glad to have you here.
Thanks.
The state of America's healthcare today, complete the sentence, is what?
I would say it's expensive, and it's the best care in the world for some of the people, some of the time.
You were just reacting to what the president said about healthcare in America and testing. What's your point?
Well, he was making a point that, you know, there are more children identified with autism today than there were 10 or 15 years ago. And I think it's important to look at pollutants in the air and various issues in the environment, but there also has been a great deal of improvement in identification and testing. My guess is that, you know, lots of people were just not identified. Certainly when I was growing up, they just were missed by the pediatricians, and now identification and early intervention has been very successful for lots of kids.
What did COVID teach us about healthcare in America, public health?
Well, I think that, you know, we learned a lot, and hopefully there will be a deep dive in looking at what we learned and doing it better the next time. Certainly some things that scientists got wrong. A lot of the social interventions, non-pharmaceutical interventions, turned out to be, I think, done with the best intentions, trying to save lives and make sure that the disease didn't spread, but had unintended consequences that we're going to be dealing with for a while, particularly for children, and isolation and depression and learning loss. The pharmaceutical breakthrough was nothing short of miraculous, and now we have a whole new way to create vaccines and expedite that process, a great public-private partnership, a lot of collaboration and communication around the world. And one of the things that we demonstrated, I think, very clearly is if you look at the death toll in America, you know, lost more than 1 million people. That's a lot of deaths in that period of time. But the differential between those who were vaccinated and those who weren't vaccinated is very stark. Once the vaccination was available, it saved millions of lives.
Can I ask you why you think COVID became such a political issue?
Boy, I wish I could tell you. It is the first time ever in this country that a public health emergency has been used as a wedge issue and a partisan issue. I was fortunate to work for a president who really believed in science and followed the science. And we had I'd say, a mini pandemic in the early days of the Obama administration, a flu strain that hadn't been seen before. Younger people had died, teachers died, kids were dying. It was pretty scary, and President Obama made it very clear that we would tell people what we know, we would tell them what we didn't know, we would follow what the scientific advice was. Luckily, we had a vaccine fairly quickly, had a massive inoculation campaign, and the disease ended up being less fatal than it initially appeared. Fast forward to the Trump era, and I think I was really alarmed the first time I saw President Trump visit the CDC and stand with Dr. Redfield, who was the head of the CDC at the time, and first announced that we had great tests that worked. We did not have a test that worked. The first testing there were tests made in Germany that worked well, but we refused to use them in the United States. We were not testing people. And he also stated that, I don't know if you remember this, there was a cruise ship off the coast of Florida, and talked about the fact that didn't want the cruise ship to dock because those numbers then would be counted as part of America's disease numbers. And I thought, holy smokes. We don't want to do testing because then our numbers will rise. And from that point on, I think there became an issue of how fast it was going to go away, what was talked about from the bully pulpit of the White House about treatments that were unproven and didn't work, and a division between what the scientific advice was and what the president was saying. And it became a very partisan issue, you know, opening up blue states, doing various things. I don't know why exactly. I think, again, it would have been healthy to have a debate about some of the social distancing, some of the lockdown strategies eventually, but it became really a partisan divide, and I think has really undermined people's confidence in public health and in science. Half of the public health workers at the state and local level left their jobs during that period of time. Some of them were driven out of office.
When President Bush left the White House, I had sat down with him, and one of the things I asked him is, will you give advice to Barack Obama? And he said, absolutely, public or private, whatever he needs. Have you given any advice to Secretary Kennedy? Have you had any conversations with him?
I had some conversations with Secretary Kennedy when I was secretary. He came to the office a couple of times, and I met with him. I have not heard from him. I'd be happy to talk to him if he wanted to talk to me.
What advice would you give him?
I would start with the fact that HHS is an incredibly important department with 13 operating divisions and touches people from cradle to grave. It's the most interactive department with states. HHS drives more money to state governments than all the other departments put together. So there's a very intertwined health partnership not just around Medicaid, but mental health and child care and foster care and adoption services, and that he should spend some time visiting each of the divisions, get to know the leadership, get to know the people, and learn about the assets of the department before massively changing direction and firing people.
So I'm sensing some concern in the tone of your voice.
Really? Have I not been clear enough? Or?
No, you've been very clear. The healthcare landscape under this administration is what? What express your public concerns about where you're worried the most?
Well, I'm worried on lots of fronts. I mean, I would love to have America healthier than we are right now. Let's just start there. That's a great goal, a great cause, a great effort.
Preventative.
Absolutely. We are, one of the richest countries in the world, the richest country in the world, and our mortality rate doesn't look very good. Americans die younger and get sicker than most of our peer countries. That's not a great place to be. So I think the efforts to look at chronic disease and infectious disease simultaneously, to not dismantle Medicaid, which is a hugely important program for 75 million people and supports healthcare across the board. I'm very worried about the congressional effort to go after Medicare. We just sang happy birthday for 60 years, but there is no more important program at the state or federal level in terms of elderly, disabled moms and kids. So I'm very worried about the massive cuts in science and research. America's engine about being the leader, the gold standard for research has been really humming away for probably 40 years. It's a great partnership with universities all over the country, and the kinds of cuts that were just announced are devastating and will set science back and research back. I live in the heartland. I live in Kansas, and Kansas State University and the University of Kansas are losing hundreds of millions of dollars on both the health side, and K-State does a lot of animal research and agriculture research, just to massively slash those programs, and they are not among the universities who get the highest amount of money. So that has a decades-long impact, and China is eager to take our place as the leader in scientific research, and they'll gladly step into any vacuum we create.
I want to come back to that point, but as the governor and HHS secretary, one of the themes today has been the disparity between urban and rural. How do we address that?
Well, the rural issue is very real. It's about access, and it's very difficult often to get healthcare providers to move to areas that aren't very well populated. Telehealth has been a real boon to rural healthcare, access to specialists, access to care that can be delivered very easily in a virtual visit, and that has been really important. I know a lot of docs who are willing to live in Western Kansas with intimate relationships with doctors in the east part of the state who help co-read radiology reports, who give advice. So having those kind of collaborative relationships. And I think we need to look very carefully at, more regionalized trauma centers and health centers to make sure that nobody lives too far away to get access to high quality care and then has local health care providers that they can get to easily. Most people don't need to be in the hospital. Let's start there. They don't want to be in the hospital. They don't need to be in the hospital. And if they have access to health providers, whether that be a doctor or a nurse practitioner or a clinic, nearby a pharmacist often plays a critical healthcare role in rural America. But it's a constant battle, and people are older and sometimes healthier in rural parts of the state. We have people who, our oldest population are in rural communities, so they need access to care, but not necessarily hospital care.
The World Health Organization, what does it do?
Well, the World Health Organization is a post-World War II collaboration of health ministers from around the world who have individuals who work together on challenges that all of us face. So sharing information about outbreaks, sharing information and access to critical medicines, looking at diseases that all of us are facing. Alzheimer's is a collaborative of the World Health Organization, sharing strategies. The United States usually sends a major delegation in May to Geneva, and which is where the headquarters of the World Health Organization are. And we meet with health ministers from across the globe, sharing strategies, sharing advice, collaborating. It is, frankly, terrifying for the health of Americans that we would withdraw from world collaboration, because diseases don't need passports, don't care about borders and boundaries. They will be in this country, and if we have to wait till something appears in this country in order to attack it, we're in really handicapped situation.
So 2 final points. If these cuts stay in place over the next 4 years, and we were here in 2027, what do you think we'd be talking about in terms of health care?
Well, if the direction that has been announced in the first 60 days is accelerated or just continues, we will lose 2 decades, I would say, of young scientists and researchers, which will set back our scientific discovery. We will, I think, have a population more vulnerable to all sorts of illnesses and possibilities, because we won't have the kind of information that is gathered when you interact globally and collaboratively. And I think, we will have allies who will not trust us anymore with information or research or clinical trials. So I think we will not just have a 4-year loss of health strategies, health information, new medicines, new scientific discoveries, but I think it will have a toll that could be a couple of decades to make up a difference.
And finally, with the passing of Jimmy Carter, healthcare also includes hospice care. What did that teach us about hospice care in America, as fortunately we were living longer, but at some point we come to our end?
I think the hospice benefit, and it was updated when I was secretary and probably needs to be updated again. So first, I think a lot of people don't understand Medicare does not pay for long-term care. Let's just start there. So a lot of people assume that it does. Only Medicaid pays for nursing home care and home health care. But a lot of people don't want to die in a hospital. They don't want to be hospitalized at the end of their life. They want to live as long as possible and die in place, die in their friends and family. I think Jimmy Carter gave a wonderful example to all of America that having some care, some medical attention around them at the end of their life allows you to, live as long as you're able to comfortably be surrounded by family and friends. My father had hospice care at the end of his life. He ended up not coming downstairs the last day. He was 93. He wasn't as old as Jimmy Carter, but it was a wonderfully peaceful and terrific way to, say goodbye. And I think hospice care provides that help and support to family and friends.
Governor, Secretary Sebelius, thank you very, very much. We appreciate it. Can you direct your attention to the monitor, please?
Decided to start this Congress off talking about how we can all support a healthier America. Employer-based health insurance covers about 55% of Americans, with about 72% of employees receiving medical benefits from their employer. This is a huge population and a space where employers can get creative in how they support a healthier workforce. Health is a huge predictor in productivity, and it is in everyone's best interest to invest in and support a healthy population. As a former employer myself, I know what it's like to want the best for my employees and what it takes to offer an attractive benefits package, with health care coverage being one of the most sought-after benefits. I also know that the government and the regulatory environment tend to make it harder on employers to take care of their employees and prevent them from offering their employees a real choice and type of coverage that works best for them. I've experienced firsthand and heard from many small business owners on the struggles they face when it comes to offering a robust health insurance package. It is our responsibility as the federal government to work with their business owners to understand what is going wrong and come up with creative solutions to fix it.
Congressman Kevin Hern, please welcome to the stage. From Kansas to Oklahoma, good to be with you.
Good to see you.
The Congressman is also the chair of the House Republican Policy Committee, so you are a real policy wonk, I guess.
That's what I'm here for, is policy. I was just sitting there thinking, we were just talking, I'm glad I didn't wear the same suit and tie. That would have been a bad look. Right?
So we just heard from you a moment ago. How do we get there? How do we make America healthy again? How do we pay for it?
Yeah, health insurance or health care in America has changed in my lifetime. When I grew up in the Ozark Mountains of Arkansas, we would go see the doctor, the family doc, or the country doc, and he would be our network administrator. And since that point in time, an old family doc told me when I was running for office in 2018 that health care is between a patient and a doctor this close, and today it's miles apart. And that every layer of that is cost. And so today, the times of people working 30 or 40 years at a job and using the company health insurance has changed. People are teleworking, they're working at different gigs, and they need to have the insurance with them. So I pushed really hard on the ICHRAs, where you have the individual health care coverage that you can take with you as an employee, and employers can reimburse you for that, pay a portion of that, and let you manage your own health care as you see fit as an individual, and use the same marketplaces to go drive those costs down.
Not sure if you heard Secretary Sebelius, but she expressed some real concerns about where things stand right now, the cutbacks in terms of DOGE and funding, and the possibility of some cutbacks at HHS. Is that looming out there?
Well, I think it is, but I think what I also heard her say is we're spending more on a per-person basis today, and she's concerned about the health of Americans today. So those are sort of those two phrases, those two bookends are what the real problem is. And even her old boss, President Obama and others back in the day, has said the same thing in the sense that there's a lot of waste in government. And so I think, as President Trump has said time and time again on the campaign trail, I'm not going to cut the benefits for those who need health care, those who deserve the health care that they need based on their economic outcomes. And listen, he has not only said that to the press, he said to us individually as members of Congress. You talked about policy. I believe that we should come together in a bipartisan way and address some of these inefficiencies and ineffectiveness of some of these policies. But he does not want to touch them. He understands that the American people are hurting from inflation. He wants to make sure that the last thing they have to worry about is their health care, should they need it and deserve it. But, we're going to look at this. We've got to find, we cannot continue going down this pathway of a $37 trillion debt, almost running $2 trillion deficits, when we've got the economic impacts of China, surrounding us around the world.
As you know, though, Elon Musk had that chainsaw. Even President Trump said maybe we need a scalpel, not a chainsaw. So how do you strike the balance to make sure that there are cutbacks, but you're not getting to the core of the people who are doing the research, the development, and the services that are needed?
I haven't talked to the president about this, but my guess is, I've been with him a lot since even before he got elected, but my guess is that you're seeing some of that pushback now with the cabinet secretaries. They want to do their job. They understand. They were elected because they had some expertise or a lot of ideas how to move forward as a cabinet secretary, just as Secretary Sebelius did, and they want to move forward. And they're seeing these cuts have been brought forth by DOGE, and they want to implement those as they see necessary to make sure their agencies are effective and efficient. So we'll see where that goes.
That excerpt from that hearing, you were hearing from employees and employers. What are they telling you? What are the biggest challenges when it comes to health care? Because the vast majority of Americans get it through the person, the employer that they work with.
Well, I think, we have 32 million small businesses in America. I've spent 40 years in business. It's very difficult to do that in Congress, obviously. So my spouse, my wife, gets to do that now. But the biggest...
And the business is what?
Well, I had, for 35 years, McDonald's franchisee, 24 restaurants in the banking world, have a manufacturing facility, 200 employees, real estate development, technology companies, the list goes on. But the most difficult thing for a small business man or woman is to attract great talent, because you're competing with benefits against major corporations that have the ability to provide health care and other benefits. So early on, I provided 401ks and very strong health care across all, from the entry level to the highest level in the organization. But it becomes very difficult. 10 years ago, you could have paid 90% of that, and the employee would pay 10%. And it just evolved to, it's flipped on its head, because the costs are so enormous that you can't pass those costs along, because your menus or your products have, they don't have the elasticity to have that absorbed. So then what happens, you start cutting benefits. And so you start losing employees to other things. And that kind of goes back to this individual health care plans that you can take with you as an individual. You can take them. So, there's a whole conversation about loyalty. For decades, businesses said employees weren't loyal to companies because of benefits. And then it sort of reversed. Companies weren't loyal to employees because of teleworking. There was no identity. And now then you just have this kind of free-for-all. And so I think as individuals that we need to have the ability to have the best health care in America, and we need to be able to afford it, and broad into markets on that's going to be the way to do it.
So this week marks the 15th anniversary of the Affordable Care Act, known as Obamacare. The president has said it's going to stay in place. If you're going to make changes to Obamacare, what will those changes be? What has to happen, if anything?
Well, again, there's been a lot of changes already made. It's not even on our radar screen right now. We're talking about other things like these individual plans. We're talking about, the big narrative in Congress today across many industries is transparency, is getting underneath the hood of many of these different agencies. I think that's what Secretary Kennedy's looking at, the transparency of what's in your food, what possibly could make it unhealthy for you through preservatives. While I believe preservatives are necessary as we feed the rest of the world, you can't just put stuff in a container car and send it, let it sit 6 months in South Africa. It has to have some kind of preservatives to allow it to happen. And you contrast that, as the Secretary was saying, is it tends to be that people are in the rural parts of America are more healthy. And I would argue one of the reasons for that is just like myself growing up in the Ozark Mountains of Arkansas, is that you used to go out and your grandmother would say, go pick it out of the garden, bring it right straight to the table, and you'd cook it. So there were no preservatives. It was straight from the garden. And that's the way much of rural America is. But that same kind of task cannot happen around the world when we're exporting food. But transparency there, transparency in the process of distortions on how our hospitals are trying to make money today. Taking a 340B program as an example, which is supposed to be low-cost pharmaceuticals, and having to use that as a revenue stream because the reimbursement rates on other services aren't where they're supposed to be. Site neutrality is using that as a revenue stream, again, because the distortions in the way that the original profit centers were set up for hospitals and service providers. We need to take a holistic look at this and see how do we get our cost structure back in place so that on a per patient basis, per citizen basis, we lower that but improve the health care.
So asking for a friend, are the McDonald's French fries healthy for you?
I will tell you this. I believe I've been around long enough, or was around long enough to see when it went from beef tallow to vegetable oil. It's does my heart good, no pun intended, to see it go back to beef tallow. That changed the flavor of fries. It really does.
And I worked at McDonald's, so I know they're delicious. One of the things that we have been seeing in Washington is a concern.
And according to the secretary, they're great for you too. I mean, Big Macs, and the president eats 2 Big Macs a day. So
Does he really?
Well, I don't know, but it sounds good, right?
Especially if they're from your McDonald's. Article 1 of the Constitution, Congress, separate but equal branch of government. Any concern that you have the executive branch basically taking over the role and Congress really not being part of this process?
You're referencing executive orders?
DOGE cuts and what we're hearing at HHS and other departments across the board.
So inside baseball. Congress has had this concern since like 1798, that the president could go and do executive orders and that Congress didn't move quick enough.
But we've never seen so many in this administration.
Well, it's because we have great reporters, right? They report a lot. And so I think when you look at that the executive orders are a lot from every president because they come in on what they believe is a mandate. I would argue also it's been a long time since we've had a president that came in that knew they only had 4 years left. Most presidents all think they're going to get reelected, just unilaterally. So they feel like they have an 8-year window to get this done. So they spread out executive orders over 8 years. President Trump learned a lot from the first 4 years, and felt like the last couple of years, I'm sure, were very challenged with COVID-19 and what it did to Americans. So many people lost their lives. That he wanted to get a lot of things done, and you have a lot of time to think about it over a 4-year pause. And so he wanted to get a lot of things implemented. And I can tell you, while people are concerned about the amount of speed that this is happening in the first 60 days, many, if not all of the things that he has done, he has brought awareness to a lot of the issues that everyday Americans care about. So we'll see where it goes. There's going to be some challenges in court. Of all the challenges over presidents over the last 100 years, President Trump has had 70% of those challenges over the last 100 years just in his term as office. So people don't like a lot of things changing. I can tell you in my 6 years in Congress, the things that's hated most up here is a lot of change. So I think he's breaking that mold, and we'll see where it goes.
So you talk about bipartisanship when it comes to your colleagues on the other side and healthcare policy in general. Where is the common ground? Where is the agreement?
Well, listen, whether you're in politics or in the legislative body or at all, you want America to be healthier. And so, you rely on the experts that kind of help you guide you. You have to also make sure that you're getting good guidance. I think also individuals, we can't politicize the ability for you to have choice on your ability to have health care, like I said, with these ICHRA plans. So while you may see in the media when we're doing our debates and the Ways and Means Committee that people are saying, well, we're trying to dissuade people from having insurance and taking away from hospitals, it's not the fact. When you talk to them on the side, away from the cameras, they get it. They like the personalized health care situation. I think the transparency is big. I think when you get into some of the not-for-profits that are paying CEOs, you may have a 100-bed hospital and CEOs are making $10 million. I can tell you there are Democrats that are very concerned, very senior Democrats that are very concerned about those distortions in pay scales for very little coverage of taking care of patients. So there are a lot of places of agreement. We have not spent a lot of time on health care. We've been spending all of our time on the reconciliation package, funding the government, things of that nature, but we will. That will be the next step.
So 2 final points, and thank you so much for being with us. Generally speaking, as a small business operator and owner, how much of your income went to pay for health care for full-time employees, approximately?
Yeah, it could be 5%. It could be 4 or 5% based on the coverage. I always tried to give the best coverage available. We had a very large, the way McDonald's system is set up, a very large health insurance company that you all would know, a lot about, and we provide that for all of our employees. And so when you look at this and you're trying to find the right mix, because you can't go out of business, so you're trying to shuffle it around. You're trying to figure out how to grow revenues to make it happen. And it really saddens you as an employer because you can't do the most for your employees. Because in a free market environment, The only thing that really separates you from being the most successful from failure is how well you take care of your employees.
So how do you strike the balance between the role of the federal government as a small business owner, healthcare policies that we have in this country, Medicare, Medicaid, the Affordable Care Act, and private businesses? Where's the balance in all of that in terms of regulation?
Yeah, I mean, when you look at, and I've spent a lot of time in this space. I sit on the health subcommittee at Ways and Means for the last 4 years, so I look at this space a lot. I look at everything I do in Congress as through the lens of a business person, because quite frankly, the reason I ran for Congress is to get government out of the way, create jobs, put Americans to work. I think that's the real change we need in this country. So I look and see where these roadblocks are. And we need, as a federal government, hold those who are abusing the things I said in transparency, the reimbursement rates, some of the loopholes. We need to close those up. We need to make sure there's equal treatment, whether it's physician-owned hospitals. They should have to take the same level of patients that a not-for-profit or a for-profit hospital takes. I think we need to look at rural America. I grew up in rural America. I think we should give the doctors that want to come together and own a small community hospital way out in the rural parts of the country. I'm a big on telehealth. We shouldn't make people drive in for just a everyday checkup. If they can get off their tractor, go into the house and have a checkup via telehealth, I'm hugely supportive of that. So all those things really matter. It's not any one thing. It's a collection of all.
Big Mac, quarter pounder, or filet of fish? What's your favorite?
Well, I mean, I'm a big filet of fish guy and Big Mac guy, but it's very difficult to eat those when you're driving down the road. So I usually go with quarter cheese.
Congressman, thank you very, very much. Appreciate it being with us. Thank you.
Thank you. Appreciate it.
Right up there.
Thanks.
So Casey Brady had a conversation with John O'Brien, the president and the CEO of the National Pharmaceutical Council. I direct your attention to the monitors.
I'm now joined by Dr. John O'Brien, who is a pharmacist and the president and CEO of the National Pharmaceutical Council. Many of you may know him as the senior advisor for drug pricing at the Department of Health and Human Services during the first Trump administration. The roles he has held across government, academia, and the biopharmaceutical and managed care industries give him a unique perspective on how policy impacts the future of health. Welcome.
Thank you. It's great to be here.
Dr. O'Brien, there is a lot of health policy in the news right now. Can you tell us what has really grabbed your attention?
Yes, but first, thank you, and thank the Hill, and thank you to Sue Peshin and the Alliance for Aging Research for bringing everybody together. This is such an important topic. When I think about what's next in health, I think that we're all going to be patients and caregivers someday. So it's so important to be focused on these incredibly important topics. When I think about my own journey in helping my parents with their health care, I can't help but think that we're living in a golden age of biomedical innovation. And when I was in pharmacy school 25 years ago, today's treatments would have been considered science fiction. And today there are millions of people who are benefiting from medicines that they didn't think that they would ever someday see to treat the diseases that they're living with. But unfortunately, we live in a system that's rife with perverse incentives. And what I mean by that is, I learned that medicines were something that could help people get well, stay healthy, and avoid more costly care settings, like hospitals. And unfortunately, there are parts of our healthcare system that seek to extract margin out of drug spending, as opposed to using medicines to help people get better. And many of the policies that we have today or are considering today in Washington may actually make this worse. So when I think about my last 5-10 years working in and out of government, I've heard from drug companies that have tried to launch a best-in-class medicine at the lowest price that pharmacy benefit managers didn't want to cover. I've met with patient groups who wanted to know why their Medicare Part D plan wasn't covering an important medicine after the manufacturer had lowered the price. And I've also met with leaders of pharmacy benefit managers who've told me that they've tried to offer low-cost solutions to the employer universe, but the employers may have actually preferred the rebates to the lower-cost medicines. So this is what all comes together to make me believe that we need as much innovation in how we pay for drugs as we do bringing new medicines to life, and I think ultimately patients are waiting for it.
So NPC's research focuses a lot on drug-related issues. We have the Inflation Reduction Act, 340B. What is your research telling you about some of these policy issues?
So NPC conducts high-quality research about the importance of patient access to scientific advancement in all of the areas that you just talked about. But I think there are two that are really important for the group that's focused here today. One, the Inflation Reduction Act. Our research has shown that that law has the potential to delay launches, reduce the number of subsequent indications or new uses for medicines after they're approved, to reduce the number of small molecule medicines that will be studied or ultimately approved, particularly in oncology or for people who are living with rare diseases. And that's also going to have a chilling effect on the kinds of research that we see after a drug is approved, which is really important to doctors and scientists to help inform clinical guidelines. But when I think about the premium stabilization demo at CMS, or I think about the Congressional Budget Office and their new higher cost estimates, I start to wonder if this law is actually going to do more harm than good. We also do a lot of research on pharmacy benefit managers and health plans. And PBM reform is such a hot topic in Washington right now. I am really interested in hearing what Mark Cuban says next. He's actually shared our research from the American Journal of Managed Care with many CEOs and business leaders. And what that research shows is that employer benefits consultants and rebate guarantees may actually play an outsized role in the decisions that pharmacy benefit managers and employers make. And that payers may actually be preferring higher cost medicines that lead to higher total pharmacy costs because they like the rebates. We've also done new research on the role of copay offset programs like accumulators and maximizers. We've done a primer explaining that topic. It's new in Health Affairs Forefront, and I encourage people to check it out or to join us on April 17th when we do a webinar with patient groups to dig deeper into that topic. But if you share NPC's vision of today's treatments and tomorrow's cures being accessible to patients, valued by society, and sustainably reimbursed by payers to ensure continued innovation, you're concerned about these problems. And that's why the importance of continuing to develop good policy based on evidence is so important.
That's some really interesting information. Thank you so much for joining us today.
Thanks for having us.
So coming up in just a couple of minutes, Julia Manchester is going to have an amazing panel dealing with an important issue of women's health. She had the chance earlier this week to have a conversation with Mark Cuban, who of course is well known for Shark Tank, his own company, and to talk about public health. So that is next, followed by our final panel. So again, direct yourself to the monitors.
Mark, thank you so much for joining us. You know, you were recently asked about a potential presidential run in 2028. You ruled it out, and I can't use your exact phrasing on that, but you said, no, I'd rather disrupt healthcare. You launched Cost Plus Drugs back in 2022. Since then, what have been some of your biggest wins and challenges?
Our wins have been considerable. We keep on growing. We keep on saving lives every day, every week. We get emails from patients saying, look, you know, I wasn't going to be able to afford my medication. I got one a couple of weeks ago from someone saying, I literally thought I would just die rather than saddling my family with the $900+ a month that I was going to have to pay. And you got it for me for $73 a month. So getting those, you know, emails and hearing from patients on an ongoing basis and from doctors, that's a huge win. We started shipping from our robotics-driven factory in Dallas, Texas. So now we're making sterile injectables. We're making biosimilars. We can pretty much make anything there. We've been shipping, geez, I guess it's been a year now. And so that's been a big win. We started Cost Plus Marketplace, just as insane as the drugs costs are for patients. The costs for clinics and hospitals are just as insane. I mean, it's like the whole entire pharmacy industry is a complete ripoff. So we started Cost Plus Marketplace for hospitals and clinics. And so we just keep on extending that and growing, you know, and just trying to do what's best for patients.
Right, and you're entering the marketplace with a number of different competitors, Costco, Amazon Prime, for example. I guess in your view, what makes Cost Plus different? What makes it stand out?
I think what makes us different is, one, our transparency. The way we work, you go to costplusdrugs.com and you put in the name of the medication. We carry over 2,500. And so if we have it, the first thing you're going to see is our actual cost. Then you see what our markup is, which is always 15%. Then if it's mail order, there's a $5 shipping fee. There's $5 for the pharmacist to review the prescription. And that's it. It's simple and it's transparent. And I think people have come to trust us because we are so transparent.
You know, you've touched on some of this already, but we know that obviously the cost of pharmaceutical drugs in this country are sky high. What does it take to make those specialty drugs more accessible to the consumer?
Very simple. Get the PBMs, the biggest PBMs in the country, to stop telling the major brand manufacturers that they'll take them off a formulary if you deal with costplusdrugs.com. It's that simple. I mean, if we were able to get access to brand medications for not even the same price as the big PBMs, but anything reasonable, when you add our 15% markup, our price is going to be dramatically lower, and you would see the cost of brand medications drop like a rock. But, when we talk to manufacturers and we say, look, why can't we get in the same rebate programs as these big PBMs? They tell us without telling us that, they don't want to lose their position on the formulary, which is, hundreds of millions or billions of dollars in sales. The big PBMs just won't let them deal with us. That is our problem, period, end of story. If we were able to get past that, I mean, we could save taxpayers billions. We could save patients tens of billions or more. That's the missing link.
So how do you get past PBMs? How do you jump over that hurdle? Is that something that's going to take time, that it will eventually come, or is that a long-term challenge?
So that's a good question. There's two elements. One, we'll always explore our legal options, but I'm not litigious at all. I really don't want to go down that path unless we absolutely have to. And two, I talk directly to self-insured employers. The CEOs of companies really don't understand how their health and pharmacy benefits work. It's not their core competency at all. And they don't realize that they are getting ripped off by these big PBMs that they're dealing with. That, I'll give you perfect examples of things that just make no sense in the deals that self-insured employers do. Most of them don't own their own claims data. 2, they can't talk to manufacturers at all. 3, they can't talk to each other. Any information about their contracts getting out at all. So they can't compare notes to get smarter. 4, there's no transparency whatsoever in the contract level, in the pricing level. 5, they don't even, they have these deals to get rebates back, and they actually don't know what their rebates are, and they can't audit them. They won't let you use an independent auditor. You have to use the auditor that they suggest. And then the biggest ripoff of all ripoffs, they have these things called specialty drugs. Often it's just, an injectable. It may be just a pill. Like there's a drug called imatinib. It's a cancer therapy. It's just a pill. And they put it on a specialty drug list and charge anywhere from hundreds to thousands of dollars versus our $21. Well, the CEOs of these companies don't realize that they're getting ripped off. So what we've been doing is going to them and working with what's called a pass-through PBM, Rightway, AffirmedRx, and others, and saying Vivio, and saying, look, work with these pass-through PBMs so you have access to all your data, all this information, all the costs, all the rebates are passed through so you actually truly get significant savings. And slowly but surely, we're having inroads. What's crazy is the biggest PBMs are now creating these products where they try to emulate us and replicate what we're doing, but they refuse to be transparent for obvious reasons. They don't want the CEOs of these companies to realize they're ripping people off. And let me add one more thing that's a big problem here. These CEOs are signing deals with these big PBMs, and as part of those deals for brand medications. So if you have a company and one of your employees or their families uses Eliquis, right? When it's time to go to the pharmacy and pick it up, that PBM that the company is working with won't even fully reimburse them for the full cost of that medication. And that's leading to thousands of independent pharmacies going out of business. And I don't think the CEOs realize, and it's not just CEOs, it's CMS, when they approve Medicare Advantage plans or Medicare Part D plans, they are approving these PBMs to under-reimburse independent pharmacies, putting independent pharmacies out of business and creating pharmacy and healthcare deserts. All these things add up. The problem was before we came along, there was nobody really working to educate CEOs in particular and CMS as well on the downstream impacts of all these things. And so we're working on it. And so directly answer your question, if we, with our pass-through PBMs, we cover about 22 million lives. If we can get up to 60 or 70 million lives, then I think that's a tilting point and the game changes. And then the manufacturers, rather than being threatened by the big PBMs, if they work with us, we'll be able to work with the same type of rebate programs, or better yet, net pricing, which is even more transparent and would actually make the pharmacies more money. The pharma manufacturers more money.
I'm going to ask a bit of a layman's question when it comes to the independent pharmacies. I rarely see an independent pharmacy. It's normally the big pharmaceutical chains where, so many of us often get our prescriptions. What is, your company's relationship with these independent pharmacies? Is there a direct line between these two? Are you looking to, grow more there?
Yeah. We have a pharmacy network called teamcubancard.com. And so if you want any of the products that we offer from Cost Plus Drugs, but you'd prefer to pick it up locally, we partner with about 17,000 pharmacies right now. Right now you have to go to teamcubancard.com to go through that process, but we're in the process of updating costplusdrugs.com to integrate the two. So to answer your question, yes, we partner with them. And what we do that's dramatically different than what the big PBMs do is when you take a prescription through Team Cuban Card to your local pharmacy, could be just the independent guy that your family's been going to for 25 years. We will pay them a $12 fill fee so that we're actually paying them for their time, and they're getting not only fully reimbursed, but they're actually making a profit on the sale of the medications as well. I want independent pharmacies to stay in business. The manufacturers want independent pharmacies to stay in business. There have been CEO, or at least one CEO of a major PBM company that said it's not his job to keep them in business. He doesn't care. I do care. I want independent pharmacies to stay in business. I think as a country, we don't want to see pharmacy deserts. We need them to stay in business. All those people, senior citizens that have been going to the same pharmacist for decades, and that pharmacist knows them, they know their family. That's important. That saves lives. And so we want them to succeed. Again, the problem is that the biggest PBMs won't fully reimburse. And the second order of that problem is literally CEOs are signing deals that under reimburse those pharmacies. CMS, HHS, the government is approving Medicare Advantage plans where they under reimburse those independent pharmacies. It's horrific. And so, hopefully all this changes. And actually, I have some high hopes for this administration to take action there.
Have you had any conversations with Secretary Kennedy or anyone from the Trump administration on this?
I can't speak to Mr. Kennedy and exactly what he's going to do, but in actually secondhand conversations, because I think I've tried to have some conversations with the administration and HHS, and I've gotten some resistance to talking to me, but going through intermediaries, the feedback I've gotten is they realize this is the problem. I got a DM today, actually, where they talked about a variety of things that will benefit independent pharmacies and patients and hopefully cut the cost of Medicare if they're able to do it, which would open the door for costplusdrugs.com to work at just a 15% markup or lower with CMS. So we'll see what happens there. But I'm hopeful.
I'm curious, you mentioned you haven't talked directly with Mr. Kennedy or the administration, but, we've chatted with Republicans who have very strong views about PBMs and getting them, in their words, under control. Have you had those conversations with Republicans?
Not since January 20th, no. I got the word that they're kind of afraid to be seen with me. That particularly Doge was afraid to work with us. But that was just from one person. Who knows how deep that goes? But I know in the past, prior to January 20th, I have talked to a variety of people. And I take that back. I did hear from the staff of one senator last week, and we exchanged ideas on how we can improve the market. And really, it just comes down to one thing: to save taxpayers and patients tens of billions of dollars, if not more. The minute Big Pharma will allow us to participate in the rebate programs, we don't need the same rebates as the big PBMs. If they get an 80% rebate, if we get a 60% rebate, when we add our 15% margin, we will cut the cost of brand medication so dramatically, we'll have the same impact that we've had on specialty generics, which is to just the prices have just dropped like a rock, and people have saved, we don't even know how much money. So if we're able to participate in these rebate programs at anything even reasonably close to what's happening now, and then just do our normal cost plus 15%, the cost of medications to taxpayers, to patients, it'll just, because we'll be transparent about it. If it's Eliquis and we're getting a 60% rebate, whatever our net cost is, plus 15%, we're going to show it and we're going to explain it to you. That's not being done right now. Literally, as crazy as it sounds, we are the only company that publishes their entire price list. So costplusdrugs.com, we'll send you our entire price list. And by the way, when the FTC examined the PBMs, they were using our data. They used our markups. They used our pricing. And when you're seeing these ERISA lawsuits where they're going at companies and saying, look, you're not living up to your fiduciary responsibility because you're not getting the best prices for medications and for care, but for medications, when those lawsuits have been filed and you dig into them or talk to them, they're telling us, we're using your pricing because you are the only price list available. So if we're able to get over this hurdle of not having rebates available to us, the amount of money that we can save taxpayers and patients will be, to paraphrase them, like you've never seen before, the most in history ever.
I want to shift a little towards politics. One big topic of conversation here in Washington is this House Republican drafted government funding bill. And, speaking of healthcare, Democrats have attacked those House Republicans for essentially, voting for what they said is a vote to defund Medicaid. House Republicans, President Trump pushed back against that, saying they do not want to defund Medicaid. I'm curious to get your thoughts on that bill and whether, how concerned you are about potential cuts to Medicaid and Social Security if this actually happens. Again, House Republicans very much pushing back on this, but wanted to get your take.
Yeah, I haven't read the bill. I mean, it's enormous apparently, yes. But I don't, I think the way I look at it as an outsider, certainly not an insider, is they're just trying to move Medicaid from the federal government to states. And so I don't think the challenge is how much money they're spending. The challenge is whether the states can handle all the additional responsibility. And, states already handle Medicaid, but, it's hard to know exactly what happens when you push all this more to them. So I just don't know enough. And it's kind of the same with Social Security. I've read on one hand that they've closed a bunch of offices. Then I read somewhere else that they were just one-person offices. And then you read elsewhere that for anybody who needs to change their direct deposit or bank account information, you can no longer make a phone call. And so if there's offices closed and you can no longer make a phone call, you might be a senior citizen that just wants to, maybe was getting too high a fees at their bank and wants to switch to a low-fee bank. And they're not online and they don't have a local Social Security Administration office, that could create problems. And I think that's the challenge.
So you would say you could potentially be open to seeing some of these programs shift to the states, but there are some concerns for you there.
Well, the devil's in the details. There's some states that have done a great job dealing with Medicaid, and maybe more money from the feds might allow them to do a better job. There's others who have not expanded Medicaid, and it's been a struggle for a lot of uninsured people in those states. So it really depends on how each state handles it.
You've ruled out running for president. Would you rule out a run for higher office, whether that's a governor's race or a Senate or House race?
Yeah, no interest.
No interest.
No interest at all.
Got it.
Well, I like, you know what? If I can get over this one hurdle on rebates for cost plus drugs, and then we're starting to work on the healthcare side, not just pharmacy, with some transparency things we're doing there. I mean, when it's all said and done, if I could change healthcare in this country, that would be amazing. I'm not saying I'm going to be able to pull it off, but I know we've had a significant impact with costplusdrugs.com. And I think getting there and focusing on that and just changing people's lives for the better on the healthcare side of things, that's my mission.
Mark Cuban, thank you so much for joining us today.
Thanks for having me.
Thank you for joining us for the White House Conference on Women's Health Research. The United States has the best health research in the world. Yet women's health is understudied and research is underfunded, and so many of you have said this. And the United States economy loses $1.8 billion in working time every year to menopause symptoms that upend women's lives.
To tee up a couple of housekeeping notes first. We saved the best for last in terms of the panel discussion. And who said there's no such thing as a free lunch? There's a free lunch here. So when this panel is over, you'll have a chance to get your free box lunch as you leave. But let me welcome back to the stage Julia Manchester from The Hill newspaper, thehill.com. Katie Schubert, who is the president and CEO of the Society for Women's Health Research. Linda Goler-Blount, she is the president and CEO of the Black Women's Health Imperative, and Robert Egge, the chief public officer of the Alzheimer's Association, for a conversation on women's health issues. Please welcome them all.
It's all good. Thanks so much, everyone. Sorry about that little reshuffling there. Thank you so much to the three of you for joining us. I'm really excited about this panel talking about women's health. Katie, let's start with you. As you heard in that opening clip from Dr. Jill Biden, women's health is obviously understudied, and research underfunded. The Biden administration, we know, made some progress in this area. Where do we stand with the Trump administration?
That's a great question. I think we're still trying to figure that out a little bit, right? And sort of as we now have an NIH director in place, an FDA commissioner, sort of trying to thread that needle a little bit. But this really was almost exactly a year ago today. The Biden administration announced an executive order related to women's health research because of all of those reasons that we just heard. And so we've never seen that level of national attention before. We've been doing this for a long time, and we're going to continue doing it. The need is there. But I think there's a great opportunity for us to sort of think about how do we continue this investment and continue the great sort of partnerships that we've all made to make sure that we're really pushing forward women's health research.
Linda, sticking with the Trump administration, we know that the administration has really zeroed in on dismantling DEI, diversity, equity, and inclusion. And I understand that you've had to make some changes at the Black Women's Health Imperative. What have the last few weeks, or I should say last few months, been like?
I think the last few months have been an exercise in flexibility and frustration management. We are a CDC grantee, and for a while our funding was hung up, and it wasn't clear that we were actually going to get the funding. We, as an organization, would have been fine, but our grantees at the state level were the ones who were going to pay the price and suffer. They were already talking about laying off employees. We have since gotten the funding, but what's interesting is sort of back-channel communication from our program officers were, as you apply for the next iteration of this grant, the next year, here is a list of words to remove. And, as the Black Women's Health Imperative, it's kind of hard to remove the word black. It's kind of hard to remove the word women.
Yeah.
And so we just proceeded in accordance with our mission. We will see what happens. We'll see if we get renewed. But we can't not be the Black Women's Health Imperative and serve Black women.
Right. Robert, I want to ask you, and switch gears just a little bit about Alzheimer's. It's a disease we've talked about quite a bit today. We know that our friends at the Alliance for Aging have talked about it. Women are more than 2 times more likely to develop Alzheimer's than men. Why is this, and sort of what is being done about it?
Yeah, so it's an interesting window into these issues broadly. The way you could explain this, first of all, the major point is we need to find out more so we can say more definitively about what I'm about to say. But there are 3 components we can point to. One is demographic. Women live longer than men, and over time that has some impact. A second reason is probably social reasons and things like that. For instance, of the generation now that's at most risk for Alzheimer's, there tend to be less education for women at that point as you roll back in time, and that we now know can have an impact. So that also accounts for a share of this double risk for women. But the third element is probably biological. And we see just this month more research that has been published on this front with, for instance, the impact of menopausal hormone therapy. And that indicates to us that that's probably the largest share right now. But we're still at a point where we can't say things definitively. We need to be able to do that.
Linda, it's interesting because oftentimes when we compare men and women, if you look at the women group in that subset, oftentimes Black women, women of color are more likely, or face different risks than white women do. Moving back to DEI or to diversity, equity, inclusion, I guess how does the DEI play a role in health outcomes in the United States?
Well, DEI, diversity, equity, inclusion, is one way of looking at data. So the fact is that not everybody experiences disease in the same way, and some populations are disproportionately, differently, or distinctly impacted by diseases. So if you look at Black women, I mean, we're all familiar with the statistics about obesity and cardiovascular disease and diabetes. These are not due to race. I mean, there's no biological or genetic determinant to race. These are in large part due to our body's response to environmental stressors, to the lack of health care, the lack of health insurance, the lack of a livable wage. There are all of these things we call the social determinants of health that impact our health. And one of the questions that could be answered through DEI is why the social determinants of health exist. Because sometimes we take them for granted. Well, that's just that. But it is, in fact, how the system is organized. So if we actually looked at the data, prioritized the health and wellness of all populations, but looked at what impacts different populations differently and distinctly, and addressed solutions from that perspective, then we could actually talk about elevating population health. And getting back to the previous speakers who said, in this country that spends the most on health care compared to any other country, has the best health care to offer, we could all actually be significantly healthier.
Katie, I want to get your perspective on the changes we've seen in DEI. You work in women's health care. I guess, how does DEI impact women across the board?
Yeah, so I mean, if you think about women in general, right, we're 51% of the population, and I would argue that we probably need to understand the effect of drugs, therapeutics, devices on the population in which you're trying to treat. And up until 1993, women were excluded from clinical research at the NIH. And so that was not long ago. So I think from the perspective of making sure that there are diverse populations included in research and that access to care and healthcare treatments are equitable, I think that makes a lot of sense to be thinking about how we do that. And so, if it's a matter of the language, that's one thing. But the reality is, again, going back to the data, if you want to find solutions, you need the data, and you can't have the data unless you're looking at these populations. And so I think it sort of all is coming together in that way. For women in particular, obviously, the diversity of women, right? We are not all the same, just like men and women are not the same. You need to make sure that you're really looking at what the population is that you're trying to reflect.
Right. Robert, one thing we've talked about quite a bit today with some of the lawmakers and other experts that have been present are the NIH cuts we've seen during the Trump administration. We know that there was a lot of progress made at the NIH on Alzheimer's funding, Alzheimer's research. How have those cuts, I think I know the answer to this question, how have they impacted that research? Where do we go from here?
It's been very disruptive. We know that every time there's a new administration, there are pauses and things. And Maybe that could explain the first few weeks, but clearly we're well beyond that. On the other hand, we have the commitment of the incoming NIH director to provide the resources we need, and we'll look forward to working with him very much on that. And foundationally, we have Congress, which had just hit with a continuing resolution, which in some regards is disappointing because there's things that we see more opportunity for with more funding for biomedical research. But nevertheless, it showed a reaffirmation from Congress at that level. In that sense, there haven't been cuts. On the other hand, for particular grants and particular programs and what you may have heard about as indirect costs that go to universities, all those things, even if the overall pot of money is still stable, those kinds of changes really disrupt the pace of progress, and it makes it very difficult to plan, which may sound like a somewhat trivial issue, but it's not at all if you're thinking about, for instance, how many new trainees do you bring in a new medical cohort. All these things really matter, and right now have thrown people off when we have to be as fast as possible in moving ahead.
You know, I want to pose a question to all of you. I was chatting earlier today on stage with Congresswoman Kim Schreier, who herself is a pediatrician or a primary care doctor, excuse me, and she was talking about how a lot of young students, medical students, it's a pretty bleak time for them going into, or researchers going into healthcare. You know, I want to hear from all of you, what's a pep talk you found yourself giving your teams about how they should navigate this environment?
Positivity, right?
Yeah.
Actually, this is something that came up, and we were up in New York recently, and there were researchers in the room, and they were researchers who were pretty young in their career, and they're looking at things like sex differences. And already that's sort of a small piece of the research ecosystem, and they were asking this very question. They're very concerned about their own health and well-being. They're concerned about how are they going to survive in terms of, making money, a place to live, et cetera. And I think from our perspective, it's about gathering those stories that we can then help to bring to Congress, I think, at this point, to really talk about the impact of this, not just on the research discoveries that we're seeing made, but truly down into sort of the trickle down of the economy in local communities, because it's not just about an NIH grant that's going to a particular researcher or institution, it's the entire ecosystem and community that we're seeing too. So really trying to stay in it, we're here to help, and let's figure out how we can really help you navigate this and make sure that we're keeping this research going.
Yeah, at a recent all-hands meeting, I said to the team, look, this is what we do. We are not going to back away from this. We are not going to be deterred by this administration. And I reminded them of the incredible work that we've accomplished. We got the PALS Act legislation passed that protected breast cancer screening at 40 for Black women. That saved 1,300 lives every year. We're CDC's top-performing diabetes program. We have launched the first ever study on breast cancer in Black women to finally answer the question of when Black women should start screening and how often. So I keep coming back to think about the incredible work that we've done and the fact that we're the ones that we're working for, the very staff. And in terms of care, since we were founded as a self-care organization, I also encourage the team, one of whom is here, take time when you need it. This is stressful. It's going to get more stressful. So just take time. We have got to practice what we preach as an organization to ourselves.
Robert,
Now, one thing that was striking to me, talking with researchers recently, has been the fact that in Alzheimer's, if you went back about 10 years or a little bit further, you'd find that we are 1/8 the size of funding that we have today. And in those times, people were discouraged. You often hear stories about leaders of labs advising their promising students to go elsewhere because you could not make a career in Alzheimer's research. Today, some of them have said it feels the same way in these months, that they're still wondering about their early promising researchers in their labs and what's their future. Yeah, I think the administration has a great opportunity right now, Dr. Bhattacharya, to just have that consistency and that normalcy come back and to be reassuring. If that can be done, then we'll still have these disruptions, but I think it'll put people back on, again, better footing for thinking about their careers, what they want to do, because we can't afford to have people step away from medical research in academic settings in particular. It's extremely important to everything that follows.
Katie, we've talked about the government's role in all of this, but why is private investment in particular so critical for fueling innovation when it comes to women's health?
Yeah, I mean, the time is now, right? As we're navigating the broader challenges of the economy and federal investment. In women's health in particular, the investment is very small. It's between 8 and 11% of the NIH budget goes toward women's health, depending on sort of what sources we're using. But I think this is a good opportunity for us to continue, right, our North Star mission to make sure that we're getting women's health research out there and we're funding it and supporting it. But we've never seen, because of this conversation that's been happening nationally, more interest and investment from the private sector. So, looking at venture capitalism, which was only at 2%, we're hoping that will go up. Looking at the pharmaceutical industry, how can we help that investment? And really think about the healthcare ecosystem and the research, continuum as well. It's not just the federal government. I think it's an obligation of all of us to make sure that we're all supporting these efforts to keep the momentum going.
Linda, from your perspective, are you seeing more interest from the private sector because of the national environment we're seeing?
Potentially, certainly in women's health. Not as much in health disparities because of, again, it's sort of the profit motive that drives some of this research and development. I mean, since the Heckler Report in 1985, $200 billion has been invested in health disparities and health equity research and programs, and here we are. And I literally had a founder say to me last year, well, there's no money in equity. Well, in fact, there is money in equity, because if we address some of the very issues that Katie spends her time talking about and you spend your time talking about, we can actually improve not only health outcomes, but economic outcomes. So it takes that kind of investment. But if people perceive that they're not going to get that return or that big exit out of whatever the therapeutic development is, then that will keep them from doing that. We have to incentivize them and help them understand that so many people would benefit from whatever that great idea is that they have. And to Katie's point, we have to get more investment. 2% of venture capital goes to women's health issues.
Yeah.
That's absurd.
Well, and sticking with that point, I'm going to sidetrack a little bit, but with the Trump administration's actions on DEI, we've seen many private companies and corporations have seemingly, maybe towed that line. Are you seeing that from your perspective? Is it impacting people's perceptions?
It is, although I have not seen it impact the behaviors, but we've seen things change on a website, we've seen words come down, but from some major foundations and funders, what I'm hearing is we're going to continue to do the work. We had to take this off the website, but we're still going to fund you and fund these issues. But they've also said, could you change your language and say it this way, just to make sure that you get the funding. So I think, yes, there's a response at perhaps the corporate leadership level, but at the level of people making these kinds of decisions, they're still very committed to these issues.
Right. Robert, we talked about Alzheimer's, but you're also giving a lot of families with a family member struggling with dementia support. How is your group doing that?
So dementia support comes in a lot of different ways, and it depends on what families can do themselves and what they depend on from state and federal government. There are two big areas. One area that we focus on a lot is making sure caregivers are equipped to handle the load that dementia brings. And it is one of the major reasons that we have caregivers today is for those families with dementia. It's often people caring for their parents in these cases. And so one way we have to be thinking about this is what a benefit that caregivers are with their generosity, which they're happy to do, but it's such a stressful and difficult job in many cases, that they're doing this and the whole country benefits. So just in the case of Alzheimer's, again, we have the case where there's about 11 million people providing care to those with dementia, volunteer, unpaid care. That's equivalent in terms of what we're paid to $350 billion per year. So if you think even in proportion of just that one disease to what's being talked about in Medicaid, you realize that when we make these decisions, whether it's caregiving for those young or old, we have to make sure that this infrastructure is in place or we're all going to lose out. Our system, although it's often invisible, depends on caregivers. And so to your question then, that's something that we are laser focused on, the Alzheimer's Association, is what can we do through advocacy and our direct support to make sure that caregivers are equipped as best they can be for these difficult jobs.
And when you mentioned caregivers, obviously there's people that come to, patients' homes and such, but are you also referring to family members, to, the children?
Exactly right. I'm glad you asked, because that's exactly who I'm referring to. Our families primarily, not only, but primarily families. Sometimes it's a spouse, sometimes a partner, sometimes it's children, adult children who are taking care of parents. It can come in all different ways, and sometimes it's friends. But that's who I'm referring to with those stats and how much we rely on this group of volunteers across the country.
Right. I want to pose another question to all of you. I guess, what are your biggest advocacy priorities? I know that we've sort of touched on them a little bit, but wanted to give you all a chance to go maybe more in depth. Katie, I'll start with you.
Sure, and I think this is fluid, right, depending on sort of what we're looking at. But I would say, in spite of the sort of federal funding environment, making sure that we're continuing the momentum surrounding women's health research and ensuring that sex differences research, so really looking at those biological differences between men and women from the beginning of your research, that's going to be really critical. The offices of women's health, which were established in the 90s and 2000s, those are something we're keeping a very close eye on across the federal agencies, and especially at the NIH, to make sure that women's health research is coordinated and prioritized across the NIH. So I would say those are really big ones, and then just really thinking about conditions that differently, disproportionately, or uniquely impact women, which is many, many things, right?
Absolutely, Linda.
And similarly, there are offices of minority health throughout the government and HHS. There's the National Institute of Minority Health and Health Disparities. We're watching to see what happens. If tomorrow it was announced that it's being defunded, nobody's going to be shocked. But we're watching. But from a policy perspective, we also have to look at maternal health. Obviously, we know the rates of Black women in maternal health. Getting HEDIS measures, quality measures, to make sure that providers provide good health. Obesity-related diseases, we're looking at what's happening on the therapeutic side with GLP-1s and access, and who doesn't have access, but also what we're doing broadly around obesity. And of course, reproductive health and rights. I mean, this is sort of our heart and soul. And so we have to be very aware, and we're engaged at both the federal and state level on these unceasing attacks on reproductive health and rights for Black women.
Robert?
Yeah, so a lot of similarities to what's already been said. A lot of what we're focused on right now is just navigating these months and advocating for what needs to happen and things we've talked about in this discussion. As we look ahead to the reconciliation conversation, there again, for Medicaid, we're making sure that we're speaking clearly about those vulnerable elderly people, in particular in the case of Alzheimer's, dementia, that rely on Medicaid so much, and how we have to take great care in how we pursue these conversations and what proposals come forward and what impacts they'd have. Also in the reconciliation bill is we were so pleased to partner with AARP and others on the Credit for Caring Act, which is a tax credit that would provide caregivers with some of the support. It's extremely expensive what they do, and that would be very timely. We're encouraged that as bipartisan support on the Hill, and also the president on the campaign trail had mentioned his support for this as well. So we think things could align for that important step forward for caregivers.
I remember the president bringing it up, and also the former vice president talking about the sandwich generation. Yes. I remember her saying that a number of times on the campaign trail. Thank you so much for all of you for joining us today. We really appreciate your time. It was a great discussion. Thank you.
Thank you.
Julia, thank you. What a superstar. Great job. Thank you all. Just a couple of housekeeping notes. First of all, there's a QR code here. We want you to sign up for the National Pharmaceutical Council for your weekly Tuesday updates on the biopharmaceutical industry. And I mention that because they are providing the free lunch, so we thank them for that. Dr. Bobby is still here. This has been a great program, but none more inspirational. So please stand up one more time. Good luck to you. Thank you. We need your leadership at the AMA, and we welcome you back for the next 30 years. So stay healthy and stay well. Thank you very much. I want to thank the team here at the Hill Events, and the tech team, and also one of our lead sponsors in all of this, of course, the Alliance for Aging Research. And to Sue, thank you all for being with us. We'll be back again in October. Enjoy the lunch. Have a great afternoon. Thanks again.